Just exactly how I
This should feel very comfortable. Very comfortable.
Well, I don't know, I'll tell it. I don't know if I can tell it,
I worked yesterday, and I was supposed to read out it.
Ronnie, are you making sure you still have a pulse? I'm caught up.
It's all right, Ronnie. You're still sitting next to a medic. You're fine.
I got you.
No, I'm retired.
So you're just gonna let me pass it? Make him. Yeah, don't say. Let's see. Like it depends on my. Just give us your verbal DNR. You don't want to.
I don't claim anything. I work
I work at the coming though.
I claim nothing. I work with mannequins only.
All good. No, all good.
Call me, I'll pick you up.
Want to turn it over to you after the end? All right, good. Okay, well, so Don and I both want to welcome you. I know you've had lots of welcomes already, right? So I'm Marjorie Lee White, for those of you I haven't met yet. I am thrilled to be welcoming you in lots of roles, but particularly as VP for Clinical Simulation for UAB Medicine. And so the space you're in is managed and operated primarily for folks who are associated with the health system and the hospital and clinics. And our program supports a mobile sim unit and supports folks all around the state. But perhaps our favorite thing to do is collaborate with OIPS and to do what we call SimUAB, which is our trademarked facilitator development program. And y'all are going to get to see pieces of that as part of your intensive. We know it's complicated, named, and all that kind of stuff. We're going to hopefully try to orient you and make sure that you also get continuing medical education if that's your wish, and continuing education for nursing for parts of things. And so we just really appreciate your being here. I also know most of you from getting to teach current trends in healthcare simulation, which is a really fun course for me, right? We added artificial intelligence this year to that course, so looking forward to seeing the rest who I haven't met there, but really looking forward to your experiences in this building this week, and then to hearing how you put them into practice in your real worlds, right? So Michelle likes for me to tell a little bit about how I became a simulationist and how that has informed what I do both as a clinician and an educator and really a simulationist. So I think actually it goes back pretty far. I was in Montessori school, and I think you got to experiment a lot. Anyone else have a Montessori connection? Maybe, tell me about it. But perhaps the formative experience I had was in what not to do in simulation. I had it happen to me as a learner in a wilderness medicine course. It happened to be a winter camping wilderness medicine course, so picture snow and should have been frozen creek, but wasn't frozen, and so what we were supposed to do was rescue what happened to be my boyfriend at the time in college. So lots of barriers, lots of challenges. The actual simulated patients got hypothermia, and we did not have a safety phrase. This is not a simulation. There was no psychological safety for me as a freshman. And so I hope that the experiences you'll have and you'll create and already are creating are really attuned to not doing some of those things, right? There were lots of challenges with that experience, and so we are really thrilled to have you here. So I'll turn over to Dawn, who's going to do her own introduction and welcome, and then we'll turn you over to April Bell, who will get us going on this afternoon of learning. So,
yes,
yeah.
So I know a couple of you in here, but for those of you I haven't met yet, I'm Dawn Taylor Peterson. I am faculty here at UAB in the School of Health Professions and the School of Medicine, and I oversee our campus-side simulation center across the way. You'll be joining us for one of your workshops this week over in our center, so I'm really excited that you're getting to see a bunch of different places where we do simulation at UAB, and so really happy to be here today with Marjorie Lee, welcoming you all for your week here. I will be seeing most of you in your instructional design course in the spring, so I also teach that course, so I haven't gotten to meet you yet. But thanks for being here. We have an exciting week ahead. We're doing lots of simulation, and we're here if you have questions.
Yeah, and I would say Dawn and I both share, if you meet someone or if you have more questions about any of the things that we're doing, we are happy to, connect about those in whatever way is helpful. You'll, I think, meet almost all of both of our teams, and we are really excited. This is a great week for y'all bringing energy and bringing your own expertise here, but we're also happy to partner, after the week happens. So,
Excellent.
happy to see friends and faces. They gave us 15 minutes to talk, and neither of us could. We would much rather you be simulating. So we are gonna move into y'all getting things done, and our team will roll with the punches because that is what they do. So without too much further ado, we'll introduce you to April Bell. She'll tell you a little bit, I'm sure, about her background, but she has been in the simulation field for, you want me to tell them how many years? 13, 14, yeah. So Kelly has been with us for 10 years, so we know that, yeah, it's been a long time. Yeah, good stuff. All right. Thanks.
Well, hello, everybody.
Hello.
Good afternoon. Take a deep breath, relax. We're going to have fun this afternoon. It's going to be a great course. It is a casual course, so feel free to engage in discussion, be interactive. If you have questions, do not leave today with your questions unanswered. Okay? Make sure you get your questions answered. All right, so I guess I'll go usually over. All right. So, where's my slide? Oh, I guess I'll just tell you. I'm April Bell. I am Director of System Simulation for UAB Clinical Simulation. I am a critical care nurse by training. I've been in simulation since 2013. I've worked with Dawn and Marjorie and Michelle for quite some time. My simulation focus is System Sim, which consists of in situ simulation. It also consists of space and process simulations. And I'll tell you a little bit more about that as we go along. As you know, I'm sure they just told you, we partner, UAB Clinical Sim partners with the Office of Interprofessional Simulation in our institution to conduct our courses and our work. Okay. So I want to share that we have no conflicts of interest. We do not promote or sell any specific brand of mannequin. And we do not have any specific vendor relationships to disclose. We also do not have any conflicts of interest or financial relationships to disclose today. If you are in need, we will be offering 4 CME for our course today, which is great news for a lot of us, especially in Alabama, because this is a renewal year for nurses. For CME for nursing in the state of Alabama, it transfers 1 credit per 1 credit. So you'll get 4 CEs if you see these 4 CMEs for the course today, which is really great news. All right, so I would like to go around the room, and I would like for you all to introduce yourselves. Have you all done this already?
You've done it with yourselves, but this is more for April and for me. Because we're going to be spending the afternoon with you.
Yeah.
So,
Yeah. Okay. I you might have to introduce yourselves. Sorry about that again. However, I would like for you to share your name, your discipline, where you work, and how you currently use SIM or plan to use SIM or your simulation interests. And just be brief. So I will start with you, Rebecca, and we'll just go around the room.
So I'm Rebecca Rose. I am from Odessa, Texas, so way west Texas.
okay.
About 3 hours outside of Dallas. I'm a nurse by trade. The last 7-8 years I've been in school nursing and been a school nurse administrator. Got my doctorate, decided that I need to give back to nursing, and ended up in the SIM lab, where right now it's primarily used by the School of Nursing as CAS training. So we haven't done any SIM, and so that's why I'm here. That's why I'm doing what I'm doing, so we can change that and hopefully improve our program, because our program is not good. I mean, we have a plan in place, and
Sure.
like things
So
are
opportunities.
Yes, lots of opportunities.
That's a good thing.
So,
Hello, my name is Natasha. I'm from Birmingham. I'm currently a disease intervention specialist with the Jeff County Department of Health. What I plan to do with simulation is to bring it to the Department of Health and to implement it in our program.
All right. We
Love
support you.
that.
All right. Thank you, Morgan.
I'm Morgan Anderson. I am a physical therapist at UAB Medicine and the critical care units for cardiovascular or cardiothoracics. So I kind of had an interest starting simulation because there's a lot of interdisciplinary training in simulation I feel like we could do, especially, mobilization is a hot topic in acute care, and PT obviously has a hand in that, but also with nursing initiating stuff too, and so, line management, all that good stuff that keep patients safe, but also up and moving.
Hey, yes, they need to move and cough and turn and be breathing.
Yeah, all the stuff.
All right, thank you. Amy?
Hi, I'm Amy Chow. I'm a simulation operations specialist at Washington State University College of Medicine. My background, I guess you could say, is in biomedical engineering, but my simulation is my first professional career. So my career interests actually involve more of defining the pathway, the direct pathway of a simulation operations specialist in our industry.
Wow.
Love it.
Thank you.
Hi, I'm Paul Moore. I am a paramedic, clinically by background. I just started a new job last week at Mount Sinai in New York City
Okay.
as the simulation education program manager. So I'd love to tell you how I'm gonna use simulation there, but I don't begin to understand it myself.
That's all right.
We support a ton of programs between the medical school.
You do.
I actually work for the medical school. I'm an employee of the medical school, technically, but we support a ton of programs much like here, between the medical school and the hospital. UME, GME, we have our own Sim Fellowship program, on and on and on.
It's a big program. You work with Jared?
Jared's my boss.
Yep, Jerry.
You know Jared.
I just texted him and I said, I can't even be at school and have my own identity because everyone wants to know about Jared.
That's right.
So yeah, that's me.
Welcome.
Thank you.
All right, LaShondra.
My name is LaShondra. I'm a nurse. for 24 years. My background is long-term care. I recently just started at University Hospital 3 years ago, working in MICU. I just started a job at our local community college. We have a STEMS lab. No one is using it, never used it, and our NCLEX scores are suffering. So.
Are you in Birmingham?
No, I'm in Mobile.
Mobile, okay.
Mobile, okay.
Okay. Well, we are happy to have you. John?
I think y'all know me a little bit.
That's right.
My name is John Andrews. I am the program manager for the Office of Standardized Patient Education here at UAB. I have been there for the last 5 years, and the reason I am here is to continue innovation and growth for our SIM Center, and continue to try to keep us at elite levels.
Yeah.
Absolutely.
Thank you.
Hannah Wilkins. I'm a pediatric emergency medicine physician at Arkansas Children's.
Oh, nice. So we got lots of friends there too.
Yeah, they all said hi.
Grace, Angela.
Yes.
Yep.
Nobody has an identity here.
I was there yesterday with them doing mock code for the
Oh,
residents.
nice.
So that's my that's how I got involved. Is I basically kind of restarted the residents mock code program.
Nice.
Because that seems to be doing well. I've also been asked to also restart and kind of take ownership of the interprofessional SIMs in the ER.
Oh,
at
very
which point
nice.
I realized I was a little out of my depth, and that's
Yeah.
when
You were with Tanya?
yes,
Okay.
Tanya and I don't know if you David Spiro.
No, I don't. Be sure to
Right.
talk to Marjorie Lee though, because she and Tanya know each other well.
She knows it.
Yeah, Tanya's one of my faculty mentors.
Oh, that's great. Great. Eric?
Small world.
Yeah, I know, I see
Very
that. Hi, my name is Eric Blake. I am the newly minted operations manager for the Belmont University Center for Interprofessional Education and Simulation.
Okay.
Beth Hallmark.
Yes.
Oh, we love Beth.
Yes.
I don't know. Dawn knows where everybody works, but I know they're all there.
Simulation is a
Yeah.
small
It's a
community.
small world.
and so
Yes. So please tell Beth that I got the whole name out, okay?
You did well.
Yeah,
Congratulations.
Yeah, thank you. So, part of course, I'm here with for the degree program, but also the main focus is to make sure that I can glean some information from all different facets of what we're doing. I get to see it and work on implementing it, in my new role. So I'm really excited to do that.
Oh, we're glad you're here.
Caitlin.
Hi, I'm Caitlin Dinsmore. I'm the SMOP specialist at the Edward Dyer College of Osteopathic Medicine's Auburn campus. I've been there for a little over 5 years, but in the SIM Center for about 3 years now. We work with DO students and certified anesthesiology assistant students. We primarily use SIM for task training and communication with standardized patients. I'm hoping with this program I can, learn a lot from everybody and take a lot of that information back to my institution to advocate for more SIM.
Yeah.
Since right now we're primarily using it for summative evaluation, and I'm really hoping to build on that formative.
Absolutely.
Good. We're in the right place.
Mitchell.
I'm Mitchell Tillman from Seattle, flight paramedic in clinical background and simulation manager. We currently use SIMs for task trainers as well, and then just ongoing scenarios for the flight crews. And they decided that they wanted to create a formalized SIM lab and program, so that's kind of what my focus is right now.
Very nice.
I'm Pam Molnar. My background is ER nursing. About 5 years ago, I became the full-time clinical instructor for our practical nursing program at Tennessee College of Applied Technology. We got a simulator through a grant, and nobody knows how to work on it. So here I am.
You need to make friends with Eric. Dennis?
I'm Dennis Kruk. I'm paramedic by trade, retired.
Hey, I want to be like you when I'm
I retired from that. I switched careers. I've been the director of the Interdisciplinary Center for Simulation at Bergen Community College, just outside Manhattan for the last 8 years. I was telling the group earlier, I work with, I think, 18 different programs, ranging from 14 to retired. And it's time we up the ante from entry-level simulation to the next level.
Thank you. Megan.
Hi, Megan Cecil from New York. I work as a paramedic in Port Jeff, and we have an EMS academy to teach the EMTs, so that's where I plan on using this.
Very nice.
Hi, I'm Ronnie.
Ronnie?
Yeah.
I-E or Y?
I-E.
Okay, write it down.
Write it down, remember it, don't forget.
You said Y?
I-E.
I-E.
See?
Ronnie.
Yes, ma'am.
Got it. Okay.
My clinical training is in athletic training, sports medicine.
Nice.
I did that for 12 years before switching to, what do I do at CBS? I'm an analyst for healthcare quality management, and so I'm the one that delivers like all the HEDIS data and gaps in care reports to the providers in our network. But before that, I taught at Oklahoma State University Center for Health Sciences in their medical and their athletic training program. And so I was able to facilitate some simulations for the athletic training students alongside the medical students. So that was my first experience in SIM, and so now I'm here to kind of keep that going while working at CVS, because I also get to work with the instructional designers too.
Did you say CVS?
CVS.
Like CVS Caremark Pharmacy?
Yes, ma'am.
Got it.
And so I work for their Medicaid side, and so I'm working with their instructional designers to create national materials to train like quality provider liaisons to deliver said gaps in care to make sure that we're closing all of those gaps.
We should talk. I worked for CVS in 2009 when I was getting my PhD in instructional design.
This is who you used to talk to.
We have lunch.
That's right. Yeah, it really is. It's kind of like left field from like, being on the sideline to, being in corporate structure. So that's
Very
still
different.
new.
Very different. Yeah. Awesome. Good chat.
Hi, my name is Jeannie San Miguel. I am from Winnipeg, Manitoba, Canada. My current role is interim director for the Clinical Competence Assessment and Digital Strategies at the University of Manitoba College of Nursing. But prior to that, my primary role was as a nurse assessor for high-stakes assessments of internationally educated nurses. So I got my foot in the door into the undergrad program acting as a sim facilitator, and then got asked to be part of the program to launch the virtual reality program. So I have experience with mannequins, virtual reality, AI, and now we're trying to integrate that into the theory of classes. So beyond the simulation lab alone and into the theory classes.
Absolutely. Oh, that's awesome. Andres is our extended reality, I would say, expert here. Augmented reality, VR, all of that. So you may want to chat with him.
Yeah, he'll be around this afternoon for sure.
Hey, I'm Bree.
Hey, Bree.
I had my first simulation experience. I was a medical student, and Dawn was my mentor back in like 2018. So yeah, they raised me. So I'm currently faculty at OHSU and working in their sim lab with medical students and residents, and also working clinically and hopefully doing some system simulations for them. So yes,
always call. My email just has not changed. Okay. Well, it's nice to meet all of you, and it seems like you have a really great group, a really pretty diverse group today, which makes the course all the more interesting. So, like I said, it's casual. Please feel free to ask your questions, make comments. Please make sure that the concepts you learned today, that you can connect them to your personal work, and do not leave with your questions unanswered. All right? So, really quickly, I want to do some housekeeping things. Restrooms. If by chance you need to use the restroom, we have a set of restrooms out by the elevator. Did you all come up the elevator? Okay. Out by that elevator, there's a set of restrooms. Out past our ice and water machine here, which is free for you to use. There probably are some cups out there if you need refreshment. Right past that ice machine is another restroom. If a line should form, find somebody in green scrubs and we can try to find you another restroom tucked away somewhere so you don't get lost. Cell phones. We all have them, need them, and love them. I am going to be the first to put mine on silent. please make sure that you silence your phones. We know that sometimes you may need to take a call. If you should need to take a phone call, please step outside of the course. We really want to make sure we maintain and limit our distractions for our work today. You might want to step out of the door and close to a window. This area has very poor cell reception. We also have phones at our desks if you need to return a call, and you can make long distance phone calls with those telephones. Just dial 9 to get out of the system. If you need to return a text, please, if it's a lot, please step out. We want to make sure that we don't distract our neighbors and friends as we work through our information today. So if you do step out, we ask that you hurry on back and join us, because we don't want you to miss any of this great content, and some of it builds on each other. So come on back and join us. So I would like for at this point, if you have not opened your folders, please, and pull out your agenda. Let's look at today. Oh, thanks. Pull out your agenda. Let's go into the day. So today we're going to hear from several of our friends in simulation. We're going to hear from Marky Harris. She's going to give us a presentation on scenario development. We will hear from Michelle Brown, who's going to give us more information about debriefing. And we will also hear from Lisa Bergman, who's going to give us a discussion on facilitating and conducting and debriefing procedural simulation. And I want to make sure to say this. Please pay special attention to Lisa's presentation. She has an amazing session on how we develop a process and how we create a checklist to follow and work through a procedure, which are very helpful skills with procedural simulation and how to take it to the next level if that's what you're aiming for.
Yeah, I was also going to say, for those of you in here who are non-clinical like me, so I do not have a clinical background. All my background is 25 plus years in education and instructional design. I don't want you to think, oh, this procedural session is not for me because I'm not clinical. Don't think that. There's so much you can glean from it, because as April said, it is about designing and developing a checklist. It's something they can all use. So I'm excited for you to experience that today.
Thank you. All right. So as we move forward, I want to let you know for this Sim 1 course today, I and Dawn are your points of contacts if you have questions or concerns. If you by chance have questions or concerns about the week's agenda or your coursework, your MSHS coursework, I would like for you to talk to Dawn or Michelle, okay? If you need help with anything around here, trying to find something, pretty much anybody in Greensboro can help you. These Greensboro. Right. So, warning. You will be a learner and a participant in a simulation and a debriefing today. Get ready for it. It's going to happen, all right? We honestly believe that as you participate in the simulation, it gives you the valuable perspective that a learner will have. And as you are working through learning to design and develop and conduct your own simulations, having the perspective of a learner will help you be more sensitive to the entire setup and experience of simulation, okay? And the purpose of today's sim is so that we can all have a common experience to talk about design and facilitation of good sim. And Dawn always shares that our friends at the Center for Medical Simulation in Boston and Cambridge, Massachusetts, they do this in their professional courses as well. And they make sure that everyone participates in the simulation. It kind of levels our playing field. And I want to make sure you understand that the simulation that we conduct today is not about your individual technical bedside skills. We're not here to assess whether you're a great nurse or a great paramedic. That's not what we're assessing today. Or even if you're a great manager or coordinator. That's not what we're assessing today. This is not about your skills or your expertise. This is just for us to have a similar experience together. Right? We're not far enough. All right. So, as we move through our conversation today, it's 2 warnings. Let you know you're gonna be upset. All right, as we move through our conversation today, we're gonna talk about 4 major buckets of things. So the first will be pre-briefing. These are the elements in orienting learners to a simulation. Next, we will talk about scenario design, which is a framework for designing an immersive simulation. And debriefing, we're going to talk about debriefing, which is the post-sim discussion where the majority of the learning happens, okay? And we're also going to discuss procedural simulation. Those are our 4 main buckets of conversation today. So to make sure that we all have the same language, have a little vocabulary lesson real fast. All right, so in-sim means in a sim center, in a sim lab, in a sim space, in a sim area where all the sim typically happens. Usually that is a non-clinical space where you don't actually see patients, all right, in simulation. We also do, we talk about in situ simulation or in situ simulation. You will hear it pronounced both ways, which means in its original location. So this type of simulation typically happens where patients are actually seen with actual clinicians during an actual clinical workday, or if you're in an office in an actual conference room with your actual colleagues. Does everybody understand the distinction? Yes, love it. I love this interactive Vietnam. I like that. Next, we've got immersive simulation. So immersive simulation is typically simulation in which there are a group of people, it could be a team of people, it could be single profession or interprofessional. Taking care of a patient with a backstory in a real specific place. It could be an inpatient location, an outpatient or ambulatory location. It could be in a cafeteria on the side of the street. Doesn't matter where it is. It's a group of people taking care of a patient as if it is real. Okay? Then you've got procedural simulation, which is typically done with a task trainer. Sometimes there can be a hybrid of simulation, but a task trainer or a body part simulating a specific procedure, inserting an IV, a Foley catheter, a central venous line, those sorts of task trainer procedural simulations. Any questions about that? All right, great. So, let's start with pre-briefing. If you would kindly open your folder and pull out your pre-briefing guide. Everybody got it? All right, so, looks pretty long, doesn't it? A lot of information. But your pre-briefing guide and the act of pre-briefing is a really important it's a really important concept to deliver at the beginning of a simulation. Okay, the pre-briefing is where we welcome our learners. It's where we kind of set the scene for how serious we are. We've got our housekeeping rules, and we also share our schedule and the purpose of our simulation. So, 1, I'm going to work through explaining the elements of pre-briefing during this time together. And 2, it's a dual purpose, so you got to pay attention. I am pre-briefing you for the simulation that you will engage in whenever it happens. Okay. So, first, I want to talk about confidentiality. So, in simulation, it's really, everything I'm going to say is really important. And I just don't have another synonym for the word important. So if you hear that word a whole bunch of times, just know they're all important. This is where we encourage our learners to keep the case details confidential. Oftentimes, we run our simulations over and over again on a different set of people. And you may find that you will do this as well. And we want that simulation experience to be fresh for group 1, and we want to keep it fresh for group 4. So we do not want our learners to share the details of the case so that everyone can have a fresh learning experience. In addition to that, it is also important to keep the performance of your peers confidential. If I walk into a simulation and I'm nervous, I may not perform in that simulation the way I would in real life, especially if everybody's watching me. And I'm in that simulation with other professions, I might get a little nervous and I might go left when I should have gone right. And I don't want to walk out of that simulation and have my friends talking about me behind my back. Can you believe April did that in the simulation? I don't want that. And I don't think any of you would want that either. So we encourage you to make sure that you keep the performance of your peers confidential in the simulation so that everyone has the same safe space to practice, learn, and grow. Because this is where those mistakes should happen if they happen, and not out with your actual professions. It also ruins psychological safety if you don't feel safe to practice in a place so that you can grow and learn and get better. And we need psychological safety to be maintained for us to have a good debriefing. And we also need to maintain it so when people come back to simulation, they have the same consistent good experience. Oftentimes, people may tell you, oh, I hate sim, or I don't like sim, and they cannot always articulate why. Oftentimes, it's because psychological safety was broken and or confidentiality. They don't feel safe in sim, or they were badgered in sim, or they were embarrassed in sim, and that is not the simulation. Those are not the techniques or philosophies that help produce good sim. Okay? Any questions? Yes.
By the way, you may think these are silly concepts. If you plan on taking the CHSE exam, there's at least 5 to 6 test questions on psychological safety
Right.
and confidentiality.
Yes, yes. I also, April, if you don't mind.
Please go ahead.
I also want to kind of set the context of this pre-briefing discussion informative simulation. So anyone in here, I know John, like that does high stakes, 4-grade OSCE assessment type simulations, some of what we're talking about would not be applicable to that setting. That's kind of a whole other ballgame. You're going to hear a lot more about that later this week. So just think as you're hearing about this pre-briefing, this is pre-briefing for formative, not for grade, immersive simulation. And I will also say if you tried some of these things in a summative OSCE, you will end up causing more damage than not. So just know that it's a different beast and it needs to be handled in a different way.
Absolutely. Thank you.
Sure.
All right. So again, for you, I will say we ask that you keep our case details confidential and the performance of your peers confidential. However, we do want you to take the lessons you learn with you and back home to your friends. Is that understood? Yes, I love this nod. Confirmatory nod. All right. So, interacting in the simulated environment. First of all, I want to say that our mannequins are not real. Shocker. In case you didn't know. Spoiler alert, they are rubber and plastic, made with mechanical parts, as well as our task trainers. They are rubber and foam and plastic. And that's okay, because we want you to engage in the simulation as if it is real, but we acknowledge that it's not. We do the very best that we can to make it real for you, to make it an experience worth your while, and we also ask that you meet us halfway with the realism, okay? The more you put into the simulation, the more you get out of it. For our simulation, you want to tell, when you're interacting in the sim environment, you want to tell people who they are, the time of day, why they're there, and what they're supposed to do. This often shows up in what we call a case stem. So this is typically how you engage the learners in a simulation with a little bit of information that tells them how to act in the simulation. Does anybody have questions about that? I want to make sure that's very clear. Okay. We'll have an example of that. So, Be who you are. Act in your role. If you are a nurse, be a nurse. If you are a doctor, be a doctor. If you are a coordinator, be a coordinator. If you're a paramedic, be a paramedic. If you're a manager, be a manager. Okay? We highly discourage you from asking your learners to be something that they are not. If you ask a nurse to pretend to be a respiratory therapist, what is that nurse learning? Absolutely nothing. They're not learning how to pretend to be a respiratory therapist. We're not asking them to do that. And if you ask one profession to pretend to be another, oftentimes what happens is they act the way they think that profession would act. So they perpetuate stereotypes that may not be true or authentic to the work of that profession. So I'm a nurse. I kind of know what a respiratory therapist does, but not intimately. They didn't go to RT school. So I have no business pretending to be a respiratory therapist in a simulation. I should just be a nurse. And if I can't be a nurse, I'm just going to be a fool. Okay? I encourage you to do the same with your learners. So today, be who you are, and as you conduct SIM, ask your learners to be who they are. Don't ask them to be something they're not. Would you like to add anything to that? I know it's a pretty important concept.
No, I think when we get to talking about the EP, we can talk a little bit about what to do. A lot of times people say, well, what do I do if I need other professions, but I don't have them? And that's where we most commonly see people assigning roles. You know, you might have a group of nursing students, and sometimes we hear people going, well, you're the scrub nurse, you're the physician, you're the tech, you're the whatever. And as April said, that's dangerous territory because you're asking them to be someone they're not, and they're going to reinforce stereotype and bias, and they're not learning anything. It just becomes frustrating when you do that. So a lot of ways that can be handled is by very specific case design and by using your EP.
So which we'll talk about that in a second. Oftentimes you may want to think about introducing your learners to your simulated environment by offering a pre-brief tour. This comes in real handy if you have like medical students, nursing students, or any type of professional students who are going to come back to your sim lab over and over and over and over again to introduce them to the mannequin. Let them see that the mannequin blinks and breathes. The mannequin has pulses, but mannequin C doesn't have a left carotid pulse because it just doesn't work. We're not trying to trick you, it's just broken. You know, you can show them where the oxygen is, where the gloves are. Yes, our sinks work. We have hand sanitizer. If you need a nasal cannula, it's in this drawer. This is where your supplies are located because we don't want to turn our simulation centers into treasure hunts. Okay? That's not very helpful when you get into true immersive simulation. Okay? So some things don't have to be a secret. Show the patient, show your learners the mannequin or the task training features and how to get a new blood pressure, how to operate the monitor so they can get these things themselves.
Yeah, can I add something?
Yeah, absolutely.
I highly encourage this. We do this with our dental students here at UAB. Dentistry comes to us, but they only come in the spring semester, and they come several times. And so we do like a day where they, not a whole day, but like one day that's not a sim day. They just come, they do a tour, they do all the things April talked about. And it also gets rid of some of that initial awkwardness where there tend to be giggles because they don't really know. They're like, oh, this is weird. This is a plastic man. He's talking to me.
And he's blinking.
And he's blinking, and this is so awkward. It kind of gets rid of the awkwardness up front, and it helps calm the nerves a little bit because they've never done sim before. And so if you have the luxury of even an hour, 30 minutes, letting them tour your center, touch the mannequin, feel the mannequin, listen to the mannequin, it calms them a little bit before they come to you.
And we have a sim where we built the pre-brief tour into the agenda. I think we have like a 2-hour agenda to do 2 cases. And part of the pre-brief and the welcome is I'm going to take you into this one room that you're going to do your simulations in. I'm going to show you this patient. Okay. The other thing about interacting in the simulated environment is it's important to share with your learners that it is not our intention to trick them or deceive them. So likewise, it is not our intention to trick you or deceive you today. And you want to let your students know what time it is. So we are in our sim center. It is present time. It is present day. Confirm it or not.
For your simulation today in our course.
All right, so now I'm going to talk about embedded participants. So you will see the terms embedded participant, and when I say the terms, you will see the terms in the literature as embedded participant, EP. You will see embedded simulated participant, which is ESP. You may see the term facilitator or scenario guide. You may also see the term confederate. All right, and it's important that you understand where that term comes from. So the term confederate, and people still use the term across
All of
the
our colleagues in Canada sometimes use
the
the
term
term
confederate.
Yeah.
So the term confederate means in on the conspiracy. And we do not feel that our simulations are conspiracies. For us, it has somewhat of an unpleasant connotation, so we tend to use the term EP or ESP. Okay, but you need to know that all of those terms are synonymous as you continue to study in your schoolwork and as you continue in your simulation professional work. Oftentimes you will see these facilitator roles as a charge nurse, a helper, they may be a family member. You can assign the EP role anything it needs to be to help push your simulation along. The particular role itself, oftentimes the EP will give the case STEM. This will be the person that comes into the room and gets the learners from the room to the STEM space. This person engages the learners. This person gives direction, but not answers. Okay? Simulation, we want people to try to get to the answers themselves with the resources that they have. And when they hit the limit of their resources, the EP can help fill in those gaps. Okay? So they ask for an ultrasound. You don't have an ultrasound machine, and you know an ultrasound machine is not coming. You just simply say, hey, I'll work on getting an ultrasound machine for you, but it might take a while because they're using it on the other unit. This way your students know or your learners know that ultrasound machine might not come and we need to just keep on going. Okay? That is one of the roles of your EP. Your EPs also offer safety and realism. So with safety, when you think about defibrillators, our defibrillators in our unit are real electricity. So you want to treat them with, the safety that you would treat your defibrillators with in an actual patient area. But when you conduct simulation in situ, that equipment is likely going to be real as well. So you want to make sure that you protect your equipment, that you protect your people, and all of your stuff. Okay? And the EP can also offer realism by helping, again, to fill in the gaps that sometimes need to be filled in. Oftentimes, learners may ask for labs that you had just didn't anticipate they would ask for. The EP can kind of fill in and say, hey, I'll work on that for you, or it's going to take 24 hours for that to come back. Just keep on, we'll work on trying to, is there anything else you want me to look for or get for you? To help kind of bridge the gap between what's real and what's not. Any questions so far, or comments or thoughts? Okay. If you encounter a problem in your simulation, your EP is the one you want to go to. And trust, the EP is not there to trick you or deceive you. Sometimes there can be technical issues that happen, or glitches just in general, and we have to keep going with what we have. So your EP can kind of help bridge that gap. Oh.
Kind of like that.
All right, just making sure you're paying attention. Your EPs can kind of help bridge that gap as well. All right? Trying to make sure. So for today, you will see EPs. You will see them. And they should have on a tag that says SimRN. So you'll know exactly who they are. All right? I also forgot to tell you, in our simulated, let me go back to this. You might see mannequins. You also may see simulated patients, which are humans. Okay. So, for the fiction contract, we know it's not real. And I mentioned this a little earlier. we try to do the best that we can to make this a good learning experience for you. And we also ask our learners to meet us halfway with what is real and what is not. The more you put into the experience, the more you'll get out of it. So again, your confirmatory nods, if you will please meet us halfway with the simulation today. No, you're not going to? All right. There's another really important concept to share with your learners as you continue in your simulation careers. It's called a safety phrase. So sometimes in simulation, people may have an actual medical emergency. And if they do, the safety phrase is, this is not a simulation. That means we stop what we're doing and we take care of you. We pause simulation and we call the right people to come and manage the patient's care. Okay? So for today, if something happens, you feel faint, dizzy, weak, say this is not a simulation, let us know, we'll sit you down and we'll take care of you. We want to make sure that we don't cry wolf with this, don't use this for fun and giggles, and we encourage you to share that with your learners as well, because we take that seriously, and if you need help, we will help you. Okay. Try to make sure I tell everybody. If you are conducting simulation outside of the sim space, in situ, or just out of lab, it is really important to use this concept if there's another patient emergency. So if you're conducting a mock code or an in situ resuscitation and an actual code gets called, that's when you say this is not a simulation, please be dismissed, empty your pockets, leave all simulated equipment and supplies in the room, go take care of it. That's a very clear distinction that needs to be made and something that needs to be consistently done and taken very seriously as you build rapport with your institutions so that your institution can trust that SIM understands the priority of patient care. Questions about that? Okay. So psychological safety. Psychological safety is an extremely important concept to hold in simulation. Oftentimes, simulation can be quite powerful. And sometimes it affects us in ways that we don't anticipate or expect. And when I say us, I mean learners as well as facilitators. When I'm thinking about sensitive topics in simulation, I'm thinking about intrauterine fetal demise, sexual assault, HIV disclosure, suicide, death and dying, things that can trigger people in ways that are unexpected. We want to practice the difficult things in a safe place. And so creating psychological safety so that we can learn, practice, grow, and talk about these things is extremely important in your simulation centers. And I encourage you to always do your best to create psychological safety so you can have true, authentic, practice-changing conversations, okay? It's extremely important. These things can be triggering to people. I have myself gotten caught off guard by a simulation. I knew it wasn't real. I knew the simulation was not real, but the EP, I just bought into it, and I cried. I had to step back and get briefing. I've been simulating for a long time, okay? You want to try to have resources available for your learners. So at UAB, for all of UAB, we have the Employee Assistance Program, which have counselors that people can talk to if for some reason they need to decompress. We also could probably call here in the hospital spiritual health and wellness to come and help us manage a person if they just need somebody to talk to right then. So think about the resources that are available in your institutions for having those types of conversations.
No. And I also think it's a really good idea, those of you who know, like if you're doing an academic setting or even not an academic setting, if you know you're going to do a simulation that involves sexual assault or that involves suicidality or that involves something super emotionally triggering, it is a good idea to find out from that faculty member, from that department director, how can we preview because there are times when if this is just for practice, a preview is appropriate. You want people to know what they're practicing, and so it is a good thing to preview and let your learners know, hey, today we're gonna be engaging in a simulation and we're working with SANE nurses to discuss sexual assault and how we collect appropriate forensic evidence. They need to know that. And we actually had a situation here many, many years ago where we had a residency group coming through that type of simulation, but one of the residents had been a victim of sexual assault in recent years. So we needed to come up with an alternative education plan for that resident, because that's not a simulation you would want that resident to engage in. And so just know that before you dive in these things, which are good things to practice, you need to be sure that you've talked to the appropriate people just to make sure that you're not causing an eruption of emotion.
And that you have resources to handle it
if it does happen unexpectedly.
Yeah.
What is not in the resources available?
Tell me more.
Meaning like, as far as like with my job, we see ages like 13, so we see sexual assault. We have to tell a 13, 14-year-old that you testify with person to that. And it causes a lot of times mental things for us having to tell them, but we don't have anything in place to help us as well as,
Let me think on that one. And so interesting. So this sounds like this is outside of a simulated setting. You're just talking about seeing a real person. Okay. Okay. Yeah. Let me think on that. And I think if you're doing it in a simulation setting, if you're simulating that conversation, do you see what I'm saying? That's a little different.
We're trying to bring it into simulation.
Yes.
And
yes.
So,
but we need to have resources. Yeah. So let's think about that. There's probably external resources that would be willing to serve as a consult if needed. I'm sure we can think on that. Yeah.
That's a good question.
It's a great question.
Any other questions or thoughts? Okay. So, the basic assumption. So I have a note here. This is what Dawn always says, and I wrote it down verbatim. This is the most important philosophical underpinning in film. Have you said that before?
I have not in front of these friends.
Okay.
Bree's laughing. I'm sure she's heard me say it.
I'm going to say it one more time. Most important philosophical underpinning in simulation is the basic assumption. It is so important, it is on our walls in here twice, in the front and the back. So the basic assumption is we believe that everyone participating in simulation activities at UAB is intelligent, capable, cares about doing their best, and wants to improve. The reason this is so important is because you will spend hours designing a simulation, and you are going to be so proud of it. And you are going to conduct that simulation. Somebody's going to come in and they're going to giggle and they are going to poo-poo all over your simulation. And you're not going to be happy about it. Okay? But pause yourself. Take a deep breath. And remember, this learner did not wake up this morning saying, I'm going to just go destroy everything I touch today. Okay? It's not typically how people wake up. So we have to maintain this idea that everyone is capable, that they care, intelligent, and they do want to improve. People may not act in sim like they always act when they're actually taking care of people, because it's not real. So it is our job as facilitators to create a space, psychologically safe space, to connect the dots for them, to sometimes help remind them as to why we are here and how this is applicable to their work when they leave this space. So if you see people giggling in simulation, take a deep breath first before you let them know how you feel about it. Okay? Take a deep breath first and say, okay, listen, I know it's not real, but this could be your mom. This could be your friend. This could be your coworker. This is going to be your next patient. So let's figure out how we're going to deal with it when you leave here. Okay? And reset the tone, because it is you are the facilitator. Okay? Also, this helps us remain curious. So you see someone giggling in the simulation, and you get to the debriefing, and you say something like, hey, I noticed there was a lot of laughter in that room, and I'm really concerned because this seems like a real serious topic to me, and a family member was really unhappy. Tell me what was going on at the time, okay? So you being curious helps you really dig into what was going on in that moment. And something really may have been funny that you just didn't see, right? Something could have been really funny. And they'll be like, oh, yeah, my shoestring popped me in the eye and then my glasses ripped off. I don't know, whatever they say. And then you can say, oh, I was concerned that you were laughing because the patient was dying. And the family was upset because it seemed to them that you weren't taking this patient's care seriously. The lesson learned there is manage your emotions during serious patient care, especially when your colleagues and your family is watching. That's the lesson learned. But you cannot get to that lesson learned if you're angry and you are belligerent before you are curious enough to investigate what was happening. That is why that is the most important philosophical underpinning in simulation. Does that make sense?
Very true, especially for those of us who work in pre-licensure, and you've done your lectures, and you've done your PowerPoints, and you've done your case studies, and you know they're going to rock it, and they get in the sim and they just blow it. And you know these learners well, and you're like, well, they're just a problem learner. They're irresponsible. If you think that walking into your debriefing, you have lost your hope of being curious. And so that's why it's so important.
Always remain curious. It is best for you
and best for them
and your learners and the patients that they will serve. Patients and people that they will serve. Your curiosity is that important. All right. Any questions about that? All right. So, debriefing. Let's talk about debriefing. Debriefing is the discussion that happens after the simulations. The purpose of debriefing is not to tell you everything you did wrong, but it's time to be curious, dig, and investigate as to why your learners did the things that they did. I wonder why so-and-so went left when they should have gone right.
Hey everyone, there's been a large pileup on the interstate and we need all hands on deck. We have a lot of patients coming up from the ER. If you guys can come with me and come help us out, that would be great.
Yes, okay, so this is the simulation. Oh, they need some help, y'all. Oh, I did the same thing too.
I love it. It's a sweet thing.
I'm gonna cut the cord soon, but I just didn't want to cut it today. That felt a lot better. Oh, that felt a lot better. The
Oh,
first
in-
time was, I was like, I
in
can't
there?
read my, no,
Yeah.
I'm about
Oh, no, it's good.
keys hit it.
Oh, she might be able to pull up next to John.
Yeah, I'm on, ain't none of them back in here yet. All right, you guys can come on back in.
Totally not the world of our lives at all. Okay, come on in. Have a seat.
Needed that.
It's really nice having a doctor.
Yeah, I'm awake now. Let's go. Yeah, look, yeah.
I want to do another one.
Couple more. Again.
Yeah. Really?
Way better the second time, right?
I
thought it went pretty well.
Try to send something right.
All right, guys.
Oh, we're good.
This is where it is. ER.
Oh, we're good.
Alright.
All right, so Andrea and I will be co-debriefing today. We're going to spend the next 20, 25-ish minutes debriefing. Typically, a debriefing will last about 30 to 45 minutes. An hour of debriefing will be kind of condensed. So I want Andrea to, hold on one second. I want to stay in the mind frame as a learner in this simulation for this debriefing. And if you have questions or comments about the elements of simulation, please hold on to that until after the debriefing, okay? So, Andrea, would you mind introducing yourself?
Hello everyone, I'm Andrea. I am a simulation educator here. I work primarily with the anesthesia residents, but I do things like Sim 1 and the EP course and other ClinSim things as well. I am a nurse by trade. Anything else you want to know?
What's your favorite color?
Green.
So, before we get started, I want to know if you could describe the experience of taking care of those patients. Please tell me how you feel in a word or a phrase.
Out of place.
Out of place.
Out of place. Just
Out of
I'm not
place.
usually in a trauma setting like that.
Out of place.
Mhm.
Okay.
Yeah, I don't like my comfort zone because that's not, ER is not my cup of tea.
Sure.
Like, I found that out a long time ago.
Anyone else?
Nostalgia.
Nostalgia.
Well, I was practicing, right, because I was pre-hospital, so I dealt with a lot of like pre-hospital emergencies, including like ankle fractures, things like that in the field, and so it's, while that setting is not my norm, it was something that I do miss because you get to take care of patients and see the immediate result. That's all.
I feel happy.
Happy?
Yeah.
Okay,
Right up
happy.
his alley. Yeah.
Tell me more about happy.
I'm with Ronnie. I miss doing this.
I got you. Okay.
Yeah, mine was familiar.
Familiar.
That was familiar. Very, very familiar.
Mm-hmm.
Comfortable.
Okay, I got comfortable, out of place. That's two extremes. Anything else?
On the flip side, unfamiliar.
Unfamiliar. Yeah. Yeah. Anyone else?
Been a long time.
Maybe a little chaotic.
Chaotic.
Yeah.
That's normal. Anyone else?
Happy to see a baby and not just adults.
Yeah. Some people are probably like, no, baby.
But I did get thrown off by the not able to get vital signs.
Yeah.
I know you asked for a word, but it was hard it was hard for me to flip the switch from facilitator to student, and I kept acting as if expecting for what they wanted to see. You know what I mean? It was hard for me to flip the switch and just play into the scenario.
That's
in a
not
way.
uncommon for you.
Yes, and we want to talk about that.
Yeah.
We're going to hold it. That's a great comment, and we're going to
Yeah.
hold it and put it over here. We're going to
I
talk
really
about
want to
that
like write it down. So
after
I
our
don't forget
meeting.
it.
Yeah.
Okay. Cognitive dissonance.
So common, yeah.
Okay. So, Andrea, would you please share with us the facts of the case?
Yes, so the facts of the case for this is you were just involved in the care of multiple patients that were in a large car pile up on the interstate, ranging from all different ages.
About how many patients do we have? Six patients. Okay. So what I want to do now is I want each room, so like one person that was in each room, give like a 1 or 2 sentence summary of what was going on with that patient in that room. So for the first room with the older gentleman, what was going on with him? Someone just give us a little synopsis of what happened.
We had a gentleman with a femur fracture and left-sided tension pneumo who was desatting. So we tried, we reduced and hemorrhaging. So we put a tourniquet on it first to control the bleeding. Then we pulled traction on the femur fracture, and then we tried a
Airway management.
well, we tried airway. So he was desatting first. So we switched from a nasal cannula to a BVM. That didn't improve. Then we tried a needle decompression. That didn't help. So we sedated him, paralyzed him, and intubated him.
Got it. Thank you. Next room, mom with baby.
And called for a chest tube.
Gotcha.
Sorry.
Mom with an 8-week-old baby, both were properly restrained. Baby was fussy but did not appear to have any obvious, at least external injuries. Mom, on initial assessment, it appears that her injuries were isolated to the right lower leg. She also was fairly stable, as far as we can tell about that. Perfect.
Thank you. How about the next room with the young patient and I believe a family member?
He was a gentleman that had pretty obvious external contusions and became hypotensive and suffered a cardiac arrest. He got massive transfusion protocol, bilateral needle decompressions, as well as airway management, and had rostrum, went to the OR. Then he had a visitor who initially was just a visitor and then had a seizure.
His brother.
Yep, his brother. And because he didn't take his Keppra, he said he was not in the car, the accident, though.
Had not eaten much.
Had not eaten, probably would have wanted to get glucose and vital signs, but all I got was heart rate because we didn't have the things. But we got him up off the floor, got him to a chair.
Okay.
He was
Did he come to? Was he ever
he's come to. He's talking the whole time. Everything's
good.
fine.
There was another patient in the hallway. Can someone tell us about her?
Female. She had a head contusion. Had been treated on the scene. Was still bleeding. Was in a bus with her uncle, and her uncle had passed on the scene and was unaware of that.
Okay. Thank you. Seems like a lot was going on. So for our conversation, I want to talk about 2 topics. One, I want to talk about teamwork and communication. Next, we're going to talk about utilization of resources. I want to first start with teamwork and communication. More specifically, I want to talk about what went well with teamwork and communication. So from your experience with those patients and your team, what went well with teamwork and communication?
I think for the man with the femoral fracture and pneumothorax, I think initially we kind of divided based on our expertises. So me and Morgan took care of the fracture with a reduction, and then while Paul and Dennis took care of the pneumothorax, and Rebecca took care of the pneumothorax, and started controlling airway management. And then once we were able to get the fracture and the tourniquet on, we were able to switch and move into different roles.
Okay.
And I think we communicated well. There were times of, I think, miscommunication, because I think protocols are different in different states, and so I think that was where there was we performed well despite that. So I think that's where we went well.
What else went well with teamwork and communication?
I can say not having a clinical background. Kaylin and I, we stayed like on the outskirts, and we needed, so we were told to help the girl that was in the hallway. And John had obviously spoken with her prior to, and he did communicate with us that her uncle had passed, because she was just asking for her uncle. So he did communicate with us outside of, in front of the patient. So I think that was good teamwork, including us not having a clinical background.
Okay, thank you. Anything else that you can think of that went well with teamwork?
I think in our center, I was with Hannah and Megan. I think when we first introduced ourselves, we outlined our profession. So we knew who the physician was, we knew who the nurse was, the paramedic, and it was almost like an automatic that everyone took a piece of the assessment. And Hannah took, I assumed Hannah took charge because she was the physician, and she did all the baby assessment, which is not my territory. So I think in terms of knowing whose role was who, it made it a little bit easier.
Absolutely.
Yeah.
Okay.
Yeah. I would say when I realized that my skills could not help that man any further in the first room, I was like, I don't know what the heck to do next. I've actually told him before, I see the nurses all go running. I don't have to do nothing like that. So I know how to squeeze back though. But that's why I was like, okay, let me go find somebody that can maybe help. And somebody's on the floor, so it's perfect. So we got him up.
Yeah, okay. So I'm hearing a couple things. One, introductions. So you all had the opportunity to introduce yourselves in these rooms. However, you may have forgotten by the time you got wherever you were, who can do what and how much and when and what your capabilities are. So it sounds to me that introductions, a simple hello, I'm a nurse, I'm a critical care nurse, I can help with intubation, or I am an adult nurse, can't help you with that, maybe. Those sorts of brief introductions and rundown of your skills can be helpful in an emergency such as this, where you may not know all of the team and the team's capabilities. Typically, we tend to work with teams that we're familiar with, so it feels that introduction is not necessary. But there are times where introductions can help make things run a lot more smoothly. I also heard you offer task assistance. So you said, I might not be able to do that, but I can do this, right?
Yeah. I was like, I do what I can.
Which is a helpful, concise way to communicate, okay? So it seems small, but it's extremely important if I know that I can put you at the head of this bed and get you just to squeeze this bed that relieves.
I was going to say, Ronnie did a good job, because he's done it before in the field, telling, I can pull traction, no problem whatsoever. You have somebody that can direct other people, that can do tasks, it definitely is helpful.
Absolutely. Anything else that you can think of that went particularly well with teamwork and communication?
Well, I initially walked in and I was working with John with that one patient. And because I got the ER background, we made sure that the patient was stabilized and understood exactly, well, this patient is related to this patient over here, and they probably need to move because there's a problem there. So once we moved that patient up and I knew that they were stabilized, they're good. And I turned around and I saw, I don't know who it was, I saw that I was doing compressions on this other patient. And I thought their body could use some help.
Yeah.
So I walked perfect. I was like, I didn't know who it was. But I saw them on the step stool, and I'm like, it was kind of like, how you doing? I could take over for you.
Yeah.
And she's like, well, you wanted, you got it.
All right.
And I jumped in and took over. So, and then just kind of the communication between everyone that was there in that particular room, because the doc communicated exactly what they wanted Mitch, he was up working on the head and making sure that the patient was intubated, you know, and then everyone kind of encouraged the other person to make sure that they stayed in their role.
Absolutely.
And this probably is off topic, but that EP was fantastic.
We're gonna hold it.
We're gonna hold it. We're gonna talk about it in a minute.
Okay.
That's after the debriefing. Yep, we're gonna talk
Thank you,
about it.
but
Thank
we
you.
want to hear it.
We want to
Okay.
hear it.
Okay. All right. So, if this happened again in 30 minutes, what might you do differently with respect to teamwork and communication? Introductions. Okay.
Assign roles.
Assign roles.
Yes.
Love that. Tell me more.
I think in our group we all worked well together and did what needed to be done, but there was definitely some overlap in effort, and having a clear leader or charge person to delegate roles probably would have made it go more smoothly.
Absolutely. So I'm hearing leadership or clear leadership, assigning roles, introductions you do differently. What else might you do differently if you did this again in 30 minutes?
Well, I think in,
Preview the room.
yeah, I don't know how many of us, certainly I didn't have much of an idea of what was going on in any of the other rooms, and so I don't think our true resource allocation was as good as it could have been.
Oh.
Just leave that right to the next.
All right. So here we go. You just did it for me. So typically, what I'm hearing you say is we probably could have benefited from an event manager. Like someone who had a little sense, like a 50,000-foot view of what was going on, because I'm sure most of you didn't realize there were 6 patients you just cared for. All right. So we typically use fundamentals from Team Steps, which is a framework for teamwork and communication from the Department of Defense that's also located on the ARHQ website. These concepts are wonderful leadership tools and teamwork tools to use for improving teamwork and communication. In addition, crisis resource management back here in the back of the room, these tenets of crisis resource management are also helpful with managing teamwork and communication. So I'm hearing an event manager, leadership for each room, delegation of roles, assigning work appropriately, distributing the workload, and introductions. These are things that I'm hearing you say could be done differently if you were to do this in the next 30 minutes. And I completely agree that these things may make caring for an emergency like this a little bit smoother. And I am thinking that if you were to do this again in 30 minutes, that you would probably take heed to some of those realizations that you've come to in this conversation. Are there any questions or comments or thoughts or additions that you'd like to make at this moment? Yes.
Can we scope out the rooms and become familiar with the equipment?
That's exactly what I was thinking. Okay.
During the break, you may. That's a good point. And let's hold that for a second.
We're gonna hold that.
And I'll talk about it
later. Yep.
Yeah. What were you gonna say?
Well, I had 2 thoughts. One of them was equipment, and the other one is what are the resources in the room?
Absolutely.
And you get to know, and if you're going to manage something, you need to know what resources you got and how to allocate them in each
So,
room.
I mean, have y'all taken the class before? Because now I'm going to shift this right on over to Andrea. Talk about utilization of resources.
Yeah, so our second thing we're going to talk about is management of resources. So first, let's talk about what do you think went well with the utilization of the resources that you had.
Well, initially, it looked like all the rooms had the right resources after people figured out what role they needed to play. So, from my perspective, the 2 spaces I looked at, that's kind of the way it appeared.
And how real, I mean, like, I was looking for trauma shears. I wanted to cut the shirt off that guy.
Yeah.
Do we cut the shirt off the guy? I mean, how realistic?
We'll hold that. We're gonna hold that.
Speaking of, I like it.
Because that has to do with simulation. Y'all are bringing up great points, but we want to get back to what Andrea was talking about. Let's think about what you all did well with utilization of resources. I heard one thing, you used the resources that you had well in each room. Anything else that you think you did well with utilization of resources?
I think for our room, getting the imaging as quickly as we did was very important for us to figure out what interventions would be the most
So you had
effective.
diagnostics.
Yeah.
Okay.
I mean, I think it might have been a coincidence that we had a pediatric physician in the room with us.
No, I picked that room on purpose.
She heard the baby, she's like, that's not scary.
Like, I guess that goes like with introductions. Like if we heard someone say that they're normally with kids, find that person and bring them to the room with a child in it.
Please.
I think we use our embedded participant a lot because we had no resources or very limited resources in a room in terms of equipment. So we were using our embedded.
You're using people.
Yes.
You were using
Your
people
to try to catch
personnel
things, to
is
make the
your
phone calls.
resource.
Yeah.
Personnel.
Human resources.
Any other,
Oh, go ahead.
anything else? So we've heard physical resources, we've heard personnel, and then knowledge of who's in the room. Anything else that you think went well with resources?
I don't know if this is resources, but I really felt good about the psychological safety of not feeling like an idiot in there.
I'm glad. That is a compliment to us. They don't want to hold that against
Hold
us.
it. Yep, that's about them.
You are where you are supposed to be, thinking about what we
Yes.
just did and how will I do this
Yep.
and how I felt about it. But I want to talk about it in a minute. All right.
If there's not anything else, then we can kind of switch our frame to think about same thing. And if you had to do this all over again, are there anything that you would do differently with the resources you had available to you?
Yeah, well, I think each individual room uses available resources well, but I think as a whole, allocation could have been more possible, because there's like 2 physicians in this group, and I was in the room with probably the 2 most stable patients, and I probably should have been somewhere else, and I just didn't think about that.
That's not uncommon.
I think we could have maybe reprioritized our resources a little better. I think we were a little discombobulated in terms of our priorities, you know?
I think that just came from our specialties. Right? Like, for me being trained in ortho mostly, like I went for the fracture, and I think that's a bias that we all suffer from when we go into the ERs.
Go do stuff we like.
Yeah, we're just like, no, this, I can do this. Well, yeah. So, but also I think that I think we could have done a better job at prioritizing the more higher tier things in our room.
Yeah, it needed a manager. It really needed a manager. So someone that should just pull all the way up and go, what else we got? What's happening?
Yeah.
What kind of resources do I have? And then allocate those resources to each of the rooms.
How do you get more resources if you don't have?
Because you can't get a surge, so you have to think about that.
So did anybody think about maybe calling for more help, more resources?
Could we have
Call for a surgeon.
Yeah, we did. You said you did call for a surgeon? Yeah.
In any of the other rooms?
Our EP made quite a few phone calls.
But I was using the resources, using the people in the room, kind of what Jeannie said.
The IEP was on it.
So I'm going to shift now to takeaways from what we've learned in our simulation and our post-sim conversation in our debrief. So if you were to leave here, go home, and this happened again, what would you take away from this experience this morning?
Have a director.
Yes, leadership's important.
Yeah, somebody that knows everyone and their skills and how to delegate.
Or can figure it out.
And or ask for more.
Clearly defined rules.
Yes, absolutely. Yes.
I'm going to go back to your discussion about the pre-brief this morning, to make sure that the participants, the learners,
Holding
see
it,
the
we're
space.
moving it. You as a learner, Dennis.
Hold it.
We're gonna hold that. We're gonna talk about that in just a second.
Well, as a learner, I want to know the space.
There. Okay. What else did you learn from that sim and this discussion?
One last thing. Anyone else?
I like being a facilitator better.
I think yeah. So let's shift our conversation and our focus completely now. So all of the things that Ms. Pam wants to talk about and the dentist wants to talk about, and anything
Paul
else.
has something
yeah,
too.
Paul has
Yeah.
something too. So the
Lots of
EPs, the
things.
things that happened this morning before your simulation that set us up for the simulation. As a facilitator, with your facilitator hat on, what did you find particularly helpful or confusing or challenging?
So
from this
Pam,
morning's
I'm gonna go on something Pam said. You talked about how great your EP was. And I think Eric made a comment too about the EP. So talk to us a little bit about that, because we want to highlight the good things, because this helps you when you go forward and train your EPs. So Pam, what was it that was so great about this EP in your room? I agree with you. He's amazing.
So even though I walked in there really not knowing what was happening and had taken a minute to orient,
Yes.
he was just like already there.
He's
like,
in
he was
it.
just like, oh, look at this. Oh, what about this?
Yep.
You know, just those verbal cues that he was just like, because I was just like, okay, what does come next? And then he was just like, oh, got this going on over here. So he was just kept everything going in real time.
Yes.
Stayed in character.
Yeah, he was in flow. He kept the flow going, which I thought was really, really important.
And I think it speaks.
No, please, go ahead.
I think when you have someone as skilled as Andrus, who's doing that, like you said, being aware and saying these things and has this flow, it helps keep you engaged, and it helps keep you from disengaging, going, well, what do I do next? I don't know what I'm supposed to do, because you have this EP who's like bringing you back and bringing you back and bringing you back. And then I also heard Hannah make a comment about how great the EP was, and Jeannie too, about the resources. You were using the EPs as you should as a colleague, and that's kind of how the EP should come across, as the colleague in the room that knows the backstory, they know the patient, but they are so on it that they're helping you stay engaged and they're getting those additional resources that you need. Because the fact of the matter is, we can never pull off a sim where we have every single thing there that a learner's going to ask for.
Absolutely.
And it's their job to go get the things that aren't there so that you feel like you're being successful in the room.
I think our EP, there was a sense of urgency without the external manifestation of the chaos. And so that sense of urgency was like, she was getting everything that we asked for amongst the organized chaos, while also allowing us to do our role by doing that. So like that sense of urgency without that externalization of panic was perfect.
EPs can be really impactful to your simulation. It's important to understand that a well-prepared EP can be extremely impactful in a positive way. Please also understand an unprepared EP can be as equally impactful in a negative way.
In a detrimental way.
Okay? Please train your EPs. Anything else about, someone mentioned pre-briefing, and then I want to talk about your tour.
I have some notes.
Yeah.
Okay.
The fiction contract.
Yeah, tell me more.
It's easy to walk into a simulation and look at it as a piece of plastic and what's the answer? What's the answer? Just keep looking for, but to commit to the role, to commit the simulation makes it that much more realistic and just to flow better.
Yes,
absolutely. Paul, was it you that mentioned pre-briefing?
I think Dennis mentioned
Dennis
pre-briefing,
pre-briefing, you mentioned
and I also
tour.
want to get to Pamela's thing about cutting the shirt off.
Okay.
Good point.
Either one. Okay, we can go either way. Let's go with your shirt cut off thing. Tell me more what's going on.
Well, that's kind of what needed to be done. I mean, our other colleague down at the end was just like, we need to get him exposed.
Yeah.
So yes, normally in the real world, I just rip my...
Were you talking about the human or a mannequin?
The mannequin.
The mannequin, okay.
I would just reach in my pocket, grab my trauma shears, and it's been done 5 minutes ago.
Okay.
So then I'm thinking, well, do we have trauma shears? And I'm looking around for them. Am I supposed to cut this shirt? You know, because it's a simulation.
Yep. So all of that dialogue you had in your head, ask your EP. because the trauma shears are in the crash cart. And can you cut the mannequin's gown? Probably. In our center you can, but at your center you're like, don't cut my shirt, I'm going to use this again. So your EP should know those details. Like, we have trauma shears, what are you trying to do? You want to cut the shirt off? Oh, we already cut it, just pull it, it's cut up the back.
Yeah.
Does that
Super
help?
important.
Yeah.
That's really great for you to know in your own centers, because each of your centers are going to be different. Because you're going to have different EPs, you're going to have different stuff. Just know that that's something you need to be really clear about in the beginning of telling your learners. If you have a question, ask the EP. They will help guide you. They're not going to lie to you or trick you.
Absolutely.
That's why you reinforce that.
Absolutely. All right, Dennis, your turn.
Talk about seeing the space. You want to see the space? Yeah?
I'm waiting for break.
Okay, well then, I'll show you the space on a break, okay? So, does anyone have any other comments or
Oh,
questions?
you had a comment at the very beginning. You wrote it down.
Yeah, it had to do with, like, flipping the script between
Oh, the
facilitator
cognitive
and
dissonance
learner.
between being a learner and a facilitator.
You wrote it down.
I did.
You didn't underline it.
Yeah,
like
I
you
did. So the thing I was going to say about that is this is one of the reasons it's so important as a facilitator to be a learner, because it is difficult, and your learners do experience the same thing. And the more advanced your learners are, if you're practicing with attending physicians, nurses that have been in practice for a long, paramedics that have been in practice for a very long time, it's a lot harder to get them to buy in.
And
so
anesthesiologists are the worst.
they can be, they can, listen, we do anesthesiology, we do, that's what Andrea does. And the level of fidelity, the physical realism in her simulations has to be extremely high, because that is what helps her meet her learning objectives. So you will learn in our next session how important designing the learning objectives are, and how it ties all of what you do as facilitators together. But your learners may have that same experience. They go in and they're instant, some of them are immediately trying to figure out, how did they make this happen? Why are they doing this? What is it they want me to do? Am I doing it right? Why aren't they giving me what I need to do it? I couldn't do it if I didn't have. So sometimes sharing the purpose of the simulation and some of your learning objectives is appropriate, and sometimes it's not. Often that is determined by the level of the learner, which is why you did not get a tour prior to your simulation. All right. Any questions, comments, concerns? We're going to move on. So I will say you all can have a break until 2:05. So that's 10 minutes, okay? If you would come back in this room at 2:05.
Thank you. We're here if you have questions.
Where do we get these?
Good question. We ordered them on the internet a long time ago.
What is the question?
The name tags are amazing.
Yes, they are.
Probably Amazon. Or Staples. Or Staples.
It's been so many years.
Great.
It's like I'm using my skills.
Yes. Oops, I did the nice thing, the nice thing. You should suck it. You said it. And I'm saying that we've had it just finished.
Yeah. Good. Sure, you guys know you guys are. I just don't look at them.
Try not to.
Oh, you can't. I was just had to go to a meeting in Dallas this last week. Get done with the conference, go back to the hotel and get checked out.
I know that we
You didn't come back and have like the 200.
No.
No, that's exactly right. That's.
You are fine.
Oh, man, you guys got it, brother.
I really
So what you been doing, man?
Well,
Sure, look at this little pop.
Sorry.
Right, yeah. I'm just gonna. And now they're all supervised. Yeah, in a good way, just in a good way. That's very helpful feedback.
It was really fun.
It really was. Love it.
Questions that I'm looking for.
This is why I'm glad you're here about it. I'm gonna pick up the time, just so you know, here in the small, sort of tangled up here. Right here. Yep. Yep. That's fine. So you will have,
Like, everything's like, it's crisscrossed around me a million times.
Yeah, it was good. Yeah, and I think that was for me too. Like I've been, doing the facilitator more for the past 5 years, and having the, switch roles.
So there's none of I was looking at you still know how to do that.
Right.
That was a great question. Who wanted two? I got a first.
Sorry,
Oh, I'm sorry. I didn't hear it. Oh, I'm sorry. Let me come here now.
So that's a great.
Probably we go that way. Okay, yeah, I'm just gonna, yeah. Yeah, okay.
So maybe.
It's the script. I'm scared to sit here.
It's an important role.
Yeah, that was on fire. I appreciate that.
Okay.
Oh, they were.
It's great.
I got 3 seconds to get in back.
Yeah.
There's a restroom in the fashion school, there's one around by the program.
Culturally very different, very different health system.
Yeah.
It's a very different patient population. So it's just a lot of change.
Yeah.
But it's been good. We made it through the year. I know. I'm excited for you. Sad for us, but excited for you. Yeah, it's so good to be back. Yeah, I was fun for there at all. Like, just got a little bit. I know. It's Here. Oh, you did?
Yeah. Oh my gosh, it just been a very long.
No, you have to get straight.
His family or the private thing?
No, well, mine.
Okay.
But my baby's all kind of spread out.
All over.
Okay. That's what tomorrow looks like. How are things from the other side?
They're good. Yeah, in a good way.
Well, that happened last time, so I mean. Y'all can't roast me. We're not the first. Okay.
So 3 hours? 2 hours?
2. But it was a long trial, full day yesterday too. So.
Well, there's a new party at 4:40. So there's all this construction.
They got the communication in the way. They know how to communicate. That's great. When you beg for really good communication, all of a sudden you get it. You know how to. Everybody knows how to communicate. You know what I'm saying? The communicators. They're answering all of my questions in full. Kind of frankly.
Kind of figure it out.
I know what's going to happen when I get back to work. I like the way they're asking. It's not what you did. It's a way she phrased that. I gotta get that. That's it. There it is.
Because I've been asking, what is on the better? It's in that middle
Nah,
poster.
you had to do it again.
I was told that she didn't know.
That is way
Sure, approve, girl. Because that was, I love that.
I figured a family member would be better to tell her than me.
Well, it's not verbatim.
Well,
I'm screwing
I
with
wouldn't
what?
want some stranger I didn't know to tell me that a family member.
I don't think so, yeah, it's so far.
So I had to try to put myself in that mindset.
Yes, and she's gonna,
Right. It was, you see what I'm saying? It's the way she phrased it that made you, didn't feel like you were trying to find out what you did. It was
feels like you're about to do it again.
Right. It was like an undertone of, I probably should fix this.
Okay, friends, is everybody back? Thank you so much for coming back from your break on time. I want to get you introduced to our next speaker, which is Marky. Marky, would you mind going ahead and introducing yourself?
Hey everybody, my name is Marky Clement Harris. I am a training coordinator here specifically for immersive simulation. I do not have a clinical background. I actually have an education background. So before this job, I was a high school instructional specialist. So I would work with our teachers and designing objectives and kind of specifically first year teachers and helping them kind of acclimate to the classroom. And we would set goals together. So not a clinician, but I'm very comfortable in simulation design as far as designing objectives and curriculum design. So before we get into STEM design, I kind of want to introduce our team in the back. So Mercedes, I'll let you start.
Hello everybody, I am Mercedes. I am a nurse practitioner, so I do have some clinical background. But I work mainly with our rural hospitals in Alabama.
Hey, good afternoon. My name is Andres Vilas. I am a nurse by training, ER, disaster response, and kind of resuscitation outcomes are kind of my areas of interest and expertise, and I'll be happy to rework. My role is predominantly with immersive simulation experiences, so I'm sure you'll learn a little bit more about what that is later, but happy to be here.
Hey guys, my name is Erica Anderson. I am a simulation coordinator, educator over on the campus side. I mainly work with, almost all are pre-licensure learners, and mostly with like the 3rd and 4th year clerkships, medicine clerkships.
Good afternoon, I'm Kelly Daly. I also work with Erica on the campus side with the Office of Interprofessional Simulation. I am a nurse by trade, that's my background. And I work mostly with 3 different courses to help them with their simulation events, physician's assistants, 1st and 2nd year med students, We throw some nursing in there too, and then also with a group that is trying to get into med school, dental school, one of those. So that's who I work with as an educator. Love doing simulation, love debriefing, so look forward to working with you.
We've already met. Andrea.
Thank you guys. So let's get into it. Do you want to introduce yourself? I'm sorry.
No, I was saying bye to them.
Okay, I was okay, sorry.
They'll come back in a minute.
Okay. So our objectives for this time together, we have about 30 minutes or so. We're going to look at how you guys are going to identify the basic components of simulation development for simulations. And you're going to collaborate with a small group later on to complete a scenario development worksheet to be used for future simulation. So we'll spend some time together in here, and then we'll go to breakout rooms with the people you just met. So let's look at the healthcare simulation standards of best practice. These were created by INACSL, which is the International Nursing Association for Clinical Simulation and Learning. It is a mouthful. So obviously this group is more dedicated to nursing, the nursing profession. However, the simulation for healthcare, simulation for healthcare, we have also adopted these standards of best practice. And so you'll see them up here, and of course today we're specifically talking about simulation design. And that design criteria is created of 11 characteristics, or 11 facets. We're going to be focusing on the first 5 today. Let me say this before I move on. This information is available to you online. So if you wanted to look up INACSL's healthcare simulation standards of best practice, it'll pop right up. Very helpful when designing sim.
It's our entire industry's standards for all professions, all of the simulation acronyms you see, everybody uses these standards.
Okay, thank you. And so here are the first 5 that we're going to focus on. We're going to talk about simulation-based experiences. How are they designed as experts? We're going to talk about a needs assessment, measurable objectives, simulation format, and then design case or scenario. The first is when you are designing a simulation-based experience, you want it designed with experts. So when designing, a huge goal for me as a simulationist is I want to have all the experts at the table. So if I'm designing a sim that requires a doctor, a nurse, a technician, a pharmacist, I want to make sure that the doctor, the nurse, the technician, they all have a seat at the table. This removes blind spots. You have people from different professions speaking to what they know best. You're including everyone in the conversation because it is a team effort, especially in interprofessional simulation. You also want your team to have some kind of sim training, whether it's formal or informal. You want them to be familiar with those standards of best practice, just to have the best outcome. And then, again, with that knowledge of simulation standards. So I need all of my careers represented. I need my people at the table, my experts, to have knowledge of what best practice looks like. And then I want to make sure that my sim, if I'm working with multiple professions, every profession is represented.
Can I add one thing?
Yes, you can.
Also, if you are designing topics that are not your specific area of expertise, like I'm a nurse, but I don't know everything, right? I'm an adult nurse. I don't do babies. I'm a critical care nurse. I'm a cardiovascular nurse. But don't put me with a neuro patient. Like, just don't do that, right? So, if you are designing content that is outside of your expertise, if it is a sensitive topic, different patient population or population specific, make sure you have those experts at your design table too. If you're going to design a DEI sim and you are not a DEI expert, diversity, equity, inclusion, call your chief diversity, equity, inclusion officer or a representative who can give you the appropriate language to help you design and help you understand what the blind spots could be in your sim. Help you design your sim so that it is appropriate for the audience with the correct language, terminology, and it is delivered appropriately. Always include experts in your design.
That's so good, thank you. Number 2 is needs assessment. So when you hear needs assessment, what does that look like to you? What would a needs assessment be? Performance gaps? Yeah. What else?
Resources.
Resources.
Clinical competencies.
Absolutely.
Goals and objectives.
Goals and objectives, yes.
be as simple as direct observation. So all the students I take care of, none of them can do this.
Yeah. Or even self-identifying. So you see it yourself, you've identified that gap. Accreditation purposes, surveys, outcome data. Your needs assessment is going to provide the evidence of the need. So when we design simulation, we've got to understand what the need is in order for that simulation to be productive and have the outcome that we want. Simulation is such a resource-intensive teaching tool that we want to make sure we're meeting our needs. Otherwise, we're just designing a really cool experience that doesn't really target our objectives. And you'll catch yourself doing this. You'll go into your scenario design room and you'll want these really fantastic ideas. And you're like, this would be so cool if our learners came into this situation, but if it doesn't meet your need, you've spent a lot of time designing a really cool sim without meeting your objectives. Would you add anything to that? Measurable objectives. Okay, here's where it gets good. Who in the room feels comfortable designing measurable learning objectives? The confidence. Who is interested in learning how to design measurable learning objectives? Everybody. Okay. We like it. We like it. Okay. So our goal for you today is not only do you leave here feeling comfortable designing learning objectives, but you're kind of committed to letting those objectives drive your entire simulation experience, right? So from the beginning, from your pre-brief all the way through your debriefing, we want you to feel comfortable relying on those objectives to kind of drive the whole thing. And so we're going to get into it. You typically we're going to recommend that you have 2 to 3 learning objectives per scenario. It gets very hairy if you go over 3 because you're trying to do too much with the time given. So 2 to 3 is your recommended number. Your objectives are going to typically fall into these 3 domains. You're going to have the cognitive domain. That's where you're thinking through the process, your critical thinking. It develops throughout the course of the simulation. You're going to have your affective. That's your feelings. So what's the emotional response? How are they processing things? How does it feel to the learner? And then you're going to have the psychomotor, which is when your brain tells your body to do a task or perform a task. So again, your objectives are going to fall into one of those categories. Your objectives can be clinical, but they can also be behavioral. So it doesn't necessarily have to be a clinical objective, and you're going to see that in just a second. So our objective format, you can see it right here. We always recommend this format. The learner participant will be able to action verb. And when choosing action verbs, I want to take a moment and kind of blurb or promote Bloom's taxonomy. So that is the leveled learning pyramid. It's going to give you great action verbs when designing your objectives. So I know myself, and I think April, you too, we have a copy of Bloom's taxonomy in our desk. It's laminated. I pull it out whenever I'm designing a sim, just for those, I can grab those verbs very quickly, and that it kind of gives you a level for where you want your learner to be as well. So you can even screenshot that on your phone when you go into your groups. I would have a designated Bloom's taxonomy person. So let's look at what this looks like. Here is an objective that I think you can use for the rest of your simulation or teaching career. Okay, we're giving it to you right here. Here's objective number 1. It's applicable in every sim because so much of what we do requires teamwork and communication strategies. So here it says learner participant will be able to demonstrate effective teamwork and communication strategies. Demonstrate is my action verb, okay? We know that that's what we want the learners to do. We want them to demonstrate. Here's the second part, as evidenced by. So if our goal is for learners to demonstrate effective teamwork and communication strategies, what does that look like? What could be evidence of that?
What are you looking for your learners to do in a simulation?
Closed loop.
Perfect.
Yes.
Closed loop. Yes.
Perfect. Oh, remember team steps and crisis resource management? That's your cheat sheet.
It is your cheat sheet. I would take a picture.
Okay.
Able to explain to a standardized or embedded parent actor what's going on with the child in lay terms.
Okay. Paraphrase. Yep. What else?
You're looking for your learners to, do you want to see them have a leader?
How do we know who the leader is?
Yes, so we want to see them delegate a leader or nominate a leader. We want to see them establish roles, delegate roles.
That's what you.
Yeah, what else do we want to see the learners do that says, yes, they are demonstrating effective teamwork and communication strategies?
The tempo, or like how well it flows?
More specifically, what? When you say how it flows.
They're able to communicate needs effectively.
Yes.
From one to another, and everybody understands.
Yes.
Absolutely.
So
Good
closed loop,
language.
did somebody already say closed loop communication? So closed loop communication is a series of call outs and check backs and summaries. You want people, the leader, to be able to summarize, okay, team, we've done this, this, and this. Is there anything else we should consider? Or is anybody opposed to calling it at this point, or blah, 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 blah. Does that make sense?
Yes.
What else would you want to see your learners do that says, aha, they are doing teamwork and communication?
That's some great teamwork. Or the opposite. I can't tell that they're working as a team, or what would stand out to you?
Well, the stuff we talked about identifying before, roles and responsibilities.
Yes. Yes.
Role delegation.
There you go. You got it.
What about seeking their opinion?
Yes. Yes. Like polling the room.
Yeah.
Which should be done in a huddle. Okay. It might be easier. We're about to create two of our own, so we can do more as evidenced by in just a second. So let's actually move to that. Let's write two objectives of our own as a group, okay? So we're going to get some hands-on. So let's say we have direct observation that we need to work on, or we want our learners to work on management of our heart attack. What would be an objective using the learner/participant will be able to blank when managing a heart attack?
Recognize symptoms.
Love it. Recognize, good verb. Perfect. I'm gonna list our verbs. Any other verbs that stand out? Are we all good with recognize?
I like to
I like recognize too.
Recognize, identify.
Yeah. I'll put identify. So I'm not worried. Recognize. Okay, help me out. So the learner participant will be able to recognize symptoms. Of heart attack, cardiac arrest. Okay, so what's that going to look like? As evidenced by,
What do you want your learners to do? What are you specifically looking for them to do in the sim that says they recognize signs and symptoms of a heart attack?
Asking the right questions.
H&P, great. History and physical. Assessment.
Focused H&P and the initial interpretation of the EKG.
Yes.
Yep.
And for my students to get the EKG.
Get the EKG. Yes. What else might you see that lets you know as a facilitator that they're on the track to recognize it?
Some of this is dependent on your level of learner, right?
Yeah, absolutely.
Tell me more.
Well, for the
I mean, if you're, this is going to change if you're writing this for first-year medical students as opposed to critical care fellows.
So, I want to talk about that, but I want to finish these objectives first.
Nobody's putting me off.
Like, they're 3 steps ahead of me.
It's coming up.
But even if she writes it down, she won't remember it.
I'm going to write it down.
Oh, I love it.
I'm going to write it down.
You're not living that down.
That's it, Morgan, you're not getting dinner now.
Okay, so this is not an exhaustive list, but it's ideas that you're generating, because let me tell you, if you are facilitating and later debriefing, it is very helpful to have this list to refer to while the sim is happening. Because, I mean, your cognitive load is already so full, right? You're trying to do a million things at once. If you have this list at the back of your mind, or really at the front of your mind while the sim is taking place, you're able to go into that debriefing with objectives to center your conversation, and you can have kind of pieces of evidence to bring into that conversation, which is going to be very helpful to you.
Either they did do that thing or they didn't.
Yeah.
And let's talk about why. Let's be curious. That make sense? Let's do it again. Let's do some more.
Okay, so we've recognized it, we've identified it. What else do we want our learners to do when managing a heart attack? Initiate, we like that. Initiate, good.
Could be calling for help. Or 911 or code, yeah.
Okay, great. So I already heard some evidence. So that looks like calling for help.
Initiating CPR.
If it gets that far.
I mean, they were still awake, right?
Yeah, we're still awake. We're still talking.
Okay, I feel better.
What else might you see?
Requesting like cardiology consult.
Yes.
Cath lab.
What else? Thank you.
Medications, please.
Management.
What we giving? Bone bash or I don't know what you give anymore. But you give something. Oxygen, nitroglycerin, labs.
Nitro, yes, nitro labs.
Anything else?
Like this.
Prepare them for the cath lab, maybe? All right.
Okay. So you have, in this STEM you just designed, well, you designed two, but we've given you 2 to 3 objectives for your scenario. So walking into this scenario, you would know that you're going to look for teamwork and communication. You're asking your learners to display or demonstrate teamwork and communication. You are asking your learners to recognize signs and symptoms, and then you're going to ask your learners to initiate treatment. So you would be, I feel, prepared to walk into a conversation, to walk into a debriefing, knowing whether your learners did these things, and then you would be curious about it. And you get to have a really great conversation based on whether they did those things or not. Questions? This was fast. You're about to design more objectives in your small groups too.
Who feels like I can do it now?
And we can do another one if need to.
We got 2 hands. I'm happy with
Okay.
you. Get 17 hands.
Okay. You're going to do it in your groups too, so I'm hoping you feel a little more confident. What's next? So those are our objectives. Let's talk about STEM format. So our team, our purpose specifically is formative assessment. So formative assessment is low stakes. Our learners are able to come in and practice. They're going to receive feedback. They're going to receive coaching. And the stakes are going to be low. They know they can mess up and not have to repeat the course or have a failing grade or something tragic happen. It's low stakes, so we're hoping that they're looking at this as a practice opportunity. The opposite of that would be summative assessment. That's when we're asking our learners to prove their knowledge or display their skills, and then there's some stakes on the line. Maybe they have to display.
They have to pass a course, pass one test to get to the next level.
Think OSCEs.
Or think graduation exam.
Yeah. It is stressful and it's high stakes, yeah. So again, here in our lab, we focus on formative assessment. Modality, you're going to have a lot of different options for modality. Is STEM taking place in the lab, or is it in situ, which is what April does a lot of. Is it immersive, or is it procedural? You could do iSTEM or e-learning computer-based STEMs, and then you have VR modules as well. So you might be wondering, how do I choose modality? And I would tell you that modality is completely decided by your objectives. So your objectives are also going to drive your modality. An example of that would be if my objective for my learners was to identify signs and symptoms of a stroke. I could use a mannequin, or I could use a human.
I'm curious what they would use.
What would you
If
use?
you had a patient that was you doing the STEM, you designing the STEM, and you want to identify signs and symptoms of a stroke, whose team mannequin?
Depends on the
Okay.
Whose team human?
Yeah.
There's
not a wrong answer.
How would you decide?
Humans can actually move and show signs, unlike mannequins, like the signs necessary for a stroke.
So how would you decide?
I would look at the level of the learner initially. So
What else?
What I have available.
Yeah.
Resources, because I don't.
Depends on the presentation.
I've done both. So how do I decide?
Depends on the type of stroke.
It depends on your objectives.
So we would be more specific and recognize stroke in our objective.
If the objective is more specific to recognizing it, human is really helpful.
Oh, treatment.
But treatment and managing it, depending on your protocols and your institutions and so on and so forth, and what else your objectives are, mannequin might be the right choice. Your objectives decide what you use and what you don't use. Does that make sense? That is such an extremely important thing to walk away with. I want you never ever to forget that. Your objectives decide what you use and how. Okay, said what I need to say.
I'm gonna use your second example too.
Yes.
So let's play again. So you want a simulation on a cardiac resuscitation, specifically on a child. Would you use a human or mannequin and why?
I would use a mannequin.
What's our objective?
Yeah.
What's the objectives?
Mannequin.
You better learn a very valuable lesson. What's your choice, human or mannequin?
What are the objectives?
Save patient. Resuscitation.
Yeah, I was about to say, just we're keeping it very general.
Successful resuscitation.
Oh.
Yeah, we're not resuscitating a little kid.
Mannequin, my bad.
Anybody still want to use a human?
No, on
Okay.
the child. No, because you can turn
Safety.
that thing on and off.
Safety is your number
On
one
and off.
concern.
Click.
Safety is your number one concern. After that, your objectives drive your choices. That makes sense? Okay. Always be safe first.
Okay. For our structure, we're going to do pre-brief, and then we move into our simulation-based learning experience, and then we end with our debrief. Again, your objectives are going to be with you throughout the whole process. You're going to rely on those objectives to drive your conversation, what the learners are doing. You're going to be tired of hearing your objectives by the end of this, but we want you just to know that your objectives are really going to carry you through the whole process. Design scenarios of the case. Okay, situation or backstory. What called you guys to our aid earlier in our disaster scenario? What was said to you?
There was a crash, and we got a lot of patients coming into the ER.
Yeah, big crash. We need your help. Come on. Did you feel like you had enough to get started?
No. That was
the bare minimum.
I mean,
well,
I knew there would.
No, you had enough to move.
Very important. You received a call.
You had enough to move.
I would take that as a compliment because, like you mentioned earlier, we considered the level of our learners. So a lot of you are experienced clinicians, and if you're not an experienced clinician, you are experienced in your own role. And so we gave you limited information because we felt confident that you could step into the room and do what needed to be done. Now, if you were nursing students, I would consider equipping you with more information, and even maybe going as far as to equip you, please step into the room, introduce yourself, and work with what you've got. Like, I would give you a little further push to get you started. The same considerations for level of learner kind of goes right into clinical progression and cues. So when you were in the rooms helping your patients, what cues or signals helped you progress the case, or you knew the case was moving on?
Facilitator.
Facilitator, yeah. What else?
Vital sign response.
Yes. What else?
Patient response.
Patient response.
So our mannequins, their eyes open wide, they can be halfway shut, they can close all the way. The mouth has a blue light inside of it, which is supposed to simulate cyanosis, or the fact that we have poor oxygenation. We have, what else? You mentioned something earlier that gave you the clue that the patient needed a reduction.
Oh, X-ray.
Yes.
There we go.
So your diagnostics, your labs, your imaging, those kinds of things help with clinical progression and cues.
No, that's perfect. So again, if I had kind of a novice learner, I might be more forward with my prompting. So if they're really struggling to ask for those labs, I might, as the EP, be like, have the labs come in yet? Or what labs were you considering? Or I would kind of prompt them a little further.
Yes.
Same with, I had, my learners were great in my room, but if, for example, like I was a mom in my room, I could be like, the baby hasn't had any formula yet, but my learners were on top of it, were already asking if they've eaten, but just kind of, as the EP, pushing your learner a little further.
So your question about level of learners, these same objectives are appropriate. What would you change about these objectives for a higher level of learning?
I'd raise the level of objectives.
Tell me more. Like, how would you change it?
So I'd want the objectives to meet the level of learner. Like For a first-year medical student, it might be enough for them to recognize a STEMI.
Sure.
But for a critical care fellow, like you want them to get into access deviation and ST depressions and all those other things.
But is recognized not still important? And I understand what you're saying. So your as evidenced by in management and treatment would change.
Okay.
But these are appropriate for any level, but what you're looking for is maybe the learner will be able to interpret EKG with
I see the
a
distinction.
higher level of precision.
Okay.
And I do understand exactly what you mean by level of learner. So yes, some of these may change. So recognize might be a little simple for a more advanced clinician, but it depends on the situation, right? Is it a female? Is it a child? Is it in a public space? Because when you take those learners outside of their regular clinical areas, things change. But what you're saying is an astute observation in making sure that our objectives meet the needs of our learners, which is why that needs assessment is so important. So thank you for helping us make that distinction very clear. Does that help?
Mm-hmm.
Okay. Proceed. Sorry.
Timeframes and scripts. So if we had an hour for our entire learning opportunity, your first 5 to 7 minutes would be dedicated to pre-brief. Okay, so pretty quick. Then your simulated learning experience would be about 10 minutes. And then with the remainder of your time, the good stuff. It's going to be your debriefing. So that's where you're really going to address learners' frames. You're going to hopefully change behaviors or dig into those behaviors, those frames. Your debriefing is the meat of your learning exercise or your learning activity. And again, that debriefing is completely driven by your objectives.
Those are the buckets of conversation that you will have. This morning, we talked about teamwork and communication, and we talked about utilization of resources. Those were our objectives, but those were our topics of discussion.
Critical actions. I think about this like branching logic. So if our learners get to this point, what are we going to do from here? Do we all have consensus of this is where the simulation is going to go? How do we know when to stop the sim? Maybe our learners are knocking out of the park and we need to up the ante a little bit. Are we all in consensus of how that's going to happen? Or what's our time frame? How long do we let them struggle? These are all things we have to consider before we even let the learners in the room. And then even how are we going to conclude this simulation? Do we feel comfortable concluding it here, or do you need to hear a certain phrase? Do they need to ask for a certain lab? And again, you want everyone on your team to be in accord, because it's really awkward if I think the sim's over and my facilitator didn't get what they needed. And now they have to go in and debrief and they're like, we didn't hit our objective. So just kind of having that consensus is really crucial. And then consider preparation and logistics. This is huge. There's so much to consider. Are these simulations taking place over a year, or are we doing them in 1 week? How many learners per simulation? Are we rotating groups? Do we have multiple rooms running? Do we have multiple EPs in the room? Are we using goulash? There's just so much to consider.
How many patient voices do we need?
Yes.
How many standardized or simulated patients do we need? How many debriefing rooms do we have? How many debriefers are available? Will I see these students again, or is this just a one and done kind of a thing? So you want to think about when you're designing your simulations, is this for a course and a conference, or is this for a course this week and I'll see them again in a month and we'll do it again the next month? So you want to think about what resources you have available and how you're designing your simulations. Does that make sense?
Keeping that big picture in mind, but then being also very detail-oriented, so both sides of the spectrum. Which I would encourage you today, this is kind of my last nugget, is to keep it simplistic. Keep it as simple as possible with your groups. This will help you, it'll kind of ground your objectives. And again, if you go back to, are we meeting a need? Are we creating objectives based on that need? It'll streamline your scenario. Questions? I know that was fast.
This is so important. Please, if you have questions, don't leave with them unanswered.
Was that 30 minutes? How was that fast?
But she wasn't playing.
Literally.
So.
She had the gas on that.
Yes.
For places with limited SIM resources, would it ever be advisable to have the same person act as the embedded participant and facilitator, or do you really need to have a separate person?
It depends. I have, so in insightful simulations, I'm the facilitator and the embedded person. You use what you have. Oftentimes, when you have an embedded person, or if you are the embedded person, it's important to leave that role with the simulation as you shift hats to debriefer. So you come in as the pre-briefer, you step out, you put on your sim tag, whoever you are now so-and-so coming to give the case stem, I'm your charge nurse, I'm your upper level physician, whatever. You participate in your EP role, and once that's done, you leave that EP hat backstage in that simulation. And when you come front stage to debriefing, you say, okay, that EP was terrible. She was mean to you, and she was not helpful. How would you navigate that with the patients you're caring for if you encounter a difficult person in the future? You leave the sim with the sim, and you move yourself forward. Or else they won't trust you. So if you're a difficult EP and you were mean to them in the sim, and you come into the debriefing and you don't make that clear distinction and leave that person, that character, that role in the sim, it's going to be hard for them to talk to you in the debriefing because you were just so mean to them. But it's not you, it was that person. Does that make sense? Okay.
Yeah, you gotta separate yourself from being one to the
Yes,
other.
you separate yourself from the role.
Uh-huh.
And leave it in the sim. Move forward as your debriefing role or whatever. Does that help? Yeah. All right. Any questions? All right. So, pull out your scenario pre-planning form. We are about to get into breakout groups. And what I want you to know is that we're going to go to separate rooms, but we're all going to come back to this room. So you don't have to take all of your stuff if you don't want to. You can just leave that. Take your pen and your paper, maybe your folder if you want, your water or whatever, and you can leave your bags. So in the first room, we are going to have Hannah, Jeannie, Latasha, and Megan. You will be with Kelly Daly in room 310. All right. Then we've got, where's Kelly? Kelly? Okay, they're coming. All right. So then we're going to have in the second group with Erica, Morgan, Eric, LaShondre, Ronnie. You're going to go with Erica into room 324. Where's Kelly? Oh, you got her group? Okay. Erica, going to go to 324. Andres and Andrea, you're going to have Rebecca, Amy, John, and Paul. You all will go to room 314. And then the rest of you all will stay in here with Mercedes and Marquis. Okay? All right. I'm gonna grab my water. All right, you have until 3:25. I'll go to Robert's. And then we'll take a break. Hey, I'm like, look, they over here. I'm joining them.
All right. I was looking at all of you guys' backgrounds, and I was like, they know this stuff, man. I was telling April, I'm like, April, how do I approach this? They know how to do this stuff. This isn't new. And she said the same way you always do it. So, with that said, pre-planning. With you guys being all very different, but with some sim foundation, I'm curious how you would start planning a simulation.
Do you want to board? Sorry,
Oh.
so I can roll it up. I
I
don't know
mean,
your process, okay?
that's great, thank you.
Figure out what our needs are.
Oh, yep. Yes. So, anything stick out to you?
As far as needs?
Mm-hmm.
Where do we get?
Where do we get? Yeah, because you're all so very different, right?
Typically, like, I'm actually just finishing up designing one of my own, and it's like we base it off of like quality manager reports that we were getting, and also including any recent like policy changes that we've implemented, like like facing cross checks or using the checklist during procedures.
That must be the time of year. I'm hearing that a lot
Oh, really?
lately. Yeah, I'm hearing a lot of quality stuff happening right now. A lot of requests for quality stuff. Who else? What else y'all got?
I just gotta help very basic students connect the dots between what they're learning in lecture and how they're gonna apply it to occasion.
Okay.
I mean, we do paper case studies, you know, and they respond well to that, but there's a big difference in going from me leading a case study to them touching on mannequins.
That makes sense. Okay.
I'm gonna say currently, I think my biggest need is basic skills. I have a lot of pre-novice learners going into associate's degree programs, and a lot of the foundational skills are subpar.
Sure. Clinical skills, nursing clinical skills?
Yeah.
Okay, gotcha. So, procedural.
Our emergency medicine board exams are changing from an oral board format to a more simulation-based format. So a lot of our objectives right now are focused around how do we prepare residents for this new exam so that they'll be successful when they leave.
I know right now our students are struggling with communication skills, especially like delivering bad news. A lot of them, don't have any like prior interaction with patients at all. So those sorts of difficult cases have been really tough on them.
Oh, you guys got a lot of good stuff to tackle. I wonder if we can encompass that into one sim together, meeting all of you guys' objectives. Do you think we can start a design from that?
That's a lot of objectives.
I think we can narrow them down, and as a group, we can negotiate that, because that's exactly what you guys do when you build sim cases anyway, right? All right, so a lot of needs, like you said, a lot of objectives. What sticks out to you being the biggest problem from all of the things that you heard?
I'm going to say communication. Maybe not necessarily delivering bad news, but just teamwork, communication in general.
I always love teamwork and communication. I don't know if you guys touched on that or not, but any simulation, and I always preach this, and you guys may preach this too, is it's not that we don't know what to do. Sometimes we know how to put an IV in, but what was left out was they had a mastectomy 2 years ago. Now that's a medical error that we have to report. So if we could talk to each other more, we would eliminate a lot of the issues. So I love teamwork and communication. That's going to go across all of it.
Yeah, that's probably a foundation for yours is communicating with your team and in the exam itself.
Yeah. Because I think that's some of the stuff that they want to assess that wasn't previously being assessed.
Yeah.
It's kind of these maybe more subjective skills.
Yeah.
Less standardized.
Yes. Any other big problems? All right, I counted to 10. Y'all did too? I kind of attend. I think I want to offer maybe the quality policy piece, regulatory requirements, because I think all of you guys kind of needed that. All right. Policy. Did you hear anything else?
I was gonna say that, or coordination of peers.
Oh, coordination. That was really good. What y'all think about that?
Yeah.
Okay. Yeah, I don't have all the answers. I don't. So, all right. Next on our sheet is our learner group. Where do we want to start with that? Novice, advanced. Do you want to train the trainer? Do you want to train your staff to train your people? Or do you want to start from your newbie students, train them, and maybe they'll get to the point where you can train others if you train them right?
Well, I'm the staff, the end. So,
Gotcha. So you prefer to train your students? You prefer to have students in our simulation? All right, students.
What are we talking about, students?
Go ahead.
What level of students is my question.
Thank you.
In what discipline? Like our nursing students, medical students, EMT students.
Gotcha.
Graduate students,
Yeah.
undergrad.
Yeah.
which is good because they all have their own scope of what they can do.
I like it. This is gonna be a great sim, y'all.
Well, what
Did
did we
everybody
decide?
vote?
I guess, yeah, do we want to?
Which students, what did we decide? What's our learning
So
group?
I hear everyone has nursing students, MD students. No students?
No.
Gotcha. What's your,
We're like flight crews, like experienced.
Ew. Experienced flight crews.
But I guess we do have like new hire that aren't like used, that are like new to the. So they're, I mean, they're going to still be the novices.
Gotcha. Okay. So you're new hires?
Yeah.
Okay. Gotcha. Post licensure. So pre and post licensure. I'm okay. I'm okay with that.
So what's our population?
Um,
Because we said a lot of different things.
We did, and our problem is communication, teamwork, policies, coordination of care. So I haven't quite got to wait, am I misinterpreting your question?
Well, I'm saying what level of, what learner group did we decide? Because we said everything from lay people to experienced providers.
I'm hearing students though.
Students, okay.
Yeah, I'm hearing nursing students, residents. So I would still say these are graduate level, like post high school. Like these are undergrad to graduate to
Non-experienced, like, I guess maybe.
still clinical though,
Yeah.
right? Okay, gotcha. So a little bit of pre
So
and post
non-experienced
licensure.
clinical providers.
And are we saying this maybe same simulation that we're designing could be used on any one of these groups? Or we're not trying to design one simulation that incorporates all those different learner populations? Because they wouldn't necessarily encounter each other in the real world very often.
Well, I guess it would depend on what we designed the simulation to be.
Right.
I mean, with coordination of care, teamwork, and quality, it could.
That's true.
It could.
Maybe
really
like a
go.
handoff
Mhm.
or a handoff of care from the flight crew to a hospital with multidisciplinary.
Mm-hmm.
Yeah, and like an SBAR simulation.
Yeah.
Look, y'all are
I was
already.
gonna say they just did it.
Yep, you guys do exactly what we all do. We skip to what like, let's design the sim
Sorry.
first, and then we're gonna go back into the objectives. So, but you're right.
I guess like clarifying like who we're designing for when we
agree.
write the objectives would be important.
I agree. So, do we all agree on these students that are undergrad, graduate, and new grads? So pre and post licensure, nursing, MD, and clinical.
Nurses,
Gotcha.
yeah.
Like they're all clinical.
Yeah.
All clinical staff. Gotcha. With a varying degree of proficiency. I like the S part. Okay.
No.
All right, now let's get to the objectives if we all agree.
The learner will be able to.
Ta-da!
Think about the situation. I mean, does that come next? Or do you just,
Say it
I mean,
again.
we've got we're working on objectives.
Mhm.
I guess we haven't got the plot somewhere yet. But how do you do the objectives before you get to, I mean, would you come up with a really great scenario and then try to apply it, or the other way around?
Yeah, the other way, because you can spend days dreaming of a scenario, and it doesn't meet your objectives, right? You can design smoke coming out of the mannequin, and your learners are like, "Yay, that was so fun!" I mean, they love it.
Yeah.
But you really wanted them to put a chest tube in. Okay? So that's why we try to come back to what are we wanting them to take away? What do we really want them to walk away going, I'm going to make sure I do this thing if I ever encounter it again.
I also think about, like, what do I want to talk about in the discussion? So that's like, sometimes if I'm struggling with my objectives, like, what are we wanting to talk about and spend our whole time debriefing? What does that look like?
I like that. Sim to debrief. That's our model.
You kind of said it earlier, but demonstrate teamwork and communication by using techniques such as SBAR and handoff structures.
Yep, I like the first one. It's perfect. Those are always my first objectives.
Oh gosh, I don't know if I can. We wrote it down earlier. The learner will be able to demonstrate teamwork and communication strategies by using techniques for structured handoff like SBAR.
Yeah, structured handoff.
Yes. I like that. And I am interjecting just a little bit with you guys. Not that I disagree, but I want to make sure that SBAR and handoff look the same across disciplines. Everyone has the same structure for SBAR handoff. Your learners have seen it before, know what it is.
Our learners are so novice, like first, second year med students, they really, like, communication is the biggest objective for the first 2 years because so much of it is didactic. Sim is typically communication, and then, you know, clinical skills are very, like, beginner. So when it comes to, like, policy and technique, they're not quite there yet.
Gotcha. I got you. How are we gonna get them there?
Do they have any tools? They need to be introduced to it.
Oh, sure.
First,
Yeah.
you know.
Yeah.
So, you know, I think having, just in general, like the sorts of stuff that's on the walls here, those sorts of visual reminders of things.
Yeah. I love cognitive aids. Do they have any?
Not really. Not in the current space that we're in, unfortunately. You know, that's something that I'm hoping to develop.
Okay. Yeah, no, you don't have to have the answers now.
Yeah.
And I'm gonna pull up, what did you guys use throughout school for?
So for like
learning?
preclinical sims, the way that they structure the curriculum where I went to school here was for each like a clerk or module, like we went through an organ systems based curriculum, and so we would do a simulation based on GI, and so there would be a clinical knowledge objective, but then also each one would have a different team steps objective. So like we would watch a video before the sim on what an SBAR is, and then when we went to the simulation, that was our communication objective. And they would kind of talk very briefly in the pre-brief, saying, you know, you were all shown a video about SBAR. Does anyone have any questions? Maybe let's try to like use that if you can in your simulation, and then people would look for a chance to use it. And that was just like very introductory the first couple of years, and then in third and fourth year they wouldn't prompt you like that, but then we would still talk about them in the debrief and say like, hey, you've talked about strategies like a huddle or like SBARC for this. I didn't hear that happen. What was going on there? Or like, is there something else we could use there? And kind of like calling back to the things that were very much prompted in first and second year. But I don't know how other people do it.
Yeah. I got just off topic, can I ask, were you guys doing simulations in your third and fourth year as well?
Yeah.
Okay. So we stop after.
So we would do at least one simulation per clerkship also, once you had got to the hospital.
Okay. And were you doing that at your like preceptorship, or were you going back to UAB to do that?
I would stop because we were very central, like we were just here the whole time.
Okay.
So it was just in a different building, which is kind of, so this is the building that we would do the clerkship simulations in, and then I guess where we're going tomorrow would be where we do the preclinical ones. So like physically the locations were different, but the structure felt very similar. It was also before they were so separated. Like at the time they were run by the same people.
So modules sounds like a good idea, some sort of learning.
Yeah, no,
So,
that's
you know,
so
the prep
cool.
work.
Like, I didn't know the answer. That's
And the team steps things I think are just on YouTube. There's like little 3-minute videos. I don't think that they were anything that we developed or that the School of Medicine developed.
Yeah, but they were like assigned to you guys.
Or like shown very quickly before the sun.
Crash course.
I know, right? I think I can't remember Michelle's last name right now. I know Brown, Dr. Brown, probably has the team steps.
And that was like 8 years ago, so it just changed.
Yeah. I need a refresh on team steps myself, but no, that's really good. So I hear you say they don't necessarily have the foundational SBAR team steps, but that's something we could do as like a pre.
Yeah, that pre-work.
Yeah, the pre-work, yeah. So I still like the SBAR handoff because we'll pre-work your people. What else should I think about for your objectives? I like the coordination of care one just to see if we can make that one.
So like a handoff in addition to SBAR? Like handing off to a flight crew?
So SBAR is probably part of coordination of care, but what's the next step? What's
the next step with your
objectives to demonstrate coordination of care?
Ensure. Do they establish roles? Do they escalate?
Well, I guess it depends on what we mean by coordination of care.
I agree.
Are we talking about coordination of care amongst the team or a multidisciplinary team? Or like calling in a cardiologist or an interventionist or just a local, you're the team leader.
I like that. Because I'm looking at you guys.
Yeah.
This is
a quarter.
Yeah.
No fair.
And maybe you don't like coordination of care. I'm okay with that. This is
Well,
is
coordination
your
of
thing.
care helps to include everybody.
Yeah.
So I like that. So we're keeping it, but including it in our teamwork and communication. Gotcha. We just don't know what that looks like yet. We don't know as evidenced by
Yeah.
the coordination of care yet.
I guess the coordination of care is probably easiest if we focus on the immediate team. Like our simulation we did this morning, was there coordination of care with that patient, with those patients? And how could we improve that?
I think probably individually in the rooms there might have been, or at least the one that I was in.
Could it have been better?
Oh yeah.
Yeah.
But I don't know, but also if you're including all of the patients within the MASH casualty, I don't know if there was.
Well, that's what I'm
that
saying.
kind of
What's the
coordination.
scope of the coordination of care?
I'm wondering if maybe the challenge that we're running into in coordination here is that we picked maybe a little bit of a vague object. Yeah, and so I think we don't, like, that means different things to everybody. So I'm wondering if maybe we take the theme and then get more specific, like what do we actually want them to be better at? Do you guys agree?
I do.
I'm wondering if our goals of teamwork and communication should be split, and communication with the SBAR, communication to handing off is the SBAR goal, and teamwork and coordination of care are linked together.
Yeah, I like
Coordination of care amongst the team.
By having like a clear leader and clear roles and
Yeah, very AHA.
yeah, kind of pit crew management or whatever the case ends up being.
Yes.
Yep, I like that.
Mm-hmm, I do too. You guys work well together.
We just met.
I know, right? And you already have teamwork and communication, displaying great communication teamwork skills.
So the learner will be able to demonstrate appropriate coordination of care by delegating roles and responsibilities.
Establishing role clarity.
You're reading what you're reading off the wall.
Please do. That's exactly why we
And
put
like,
them
that's
there.
by establishing role
That's
clarity.
exactly
Fantastic.
why we put them there.
Are they in the other rooms too, or are we the only ones?
They are.
You could do a twofer there. You can establish role clarity and mobilize resources, because that's coordinating care. If I ever, this is nice. This is nice. Well, I can, you know, I read walls pretty well. Using my cognitive aids.
Please,
Using
yes.
my
They take them through it.
Yes.
I use it all the time.
And it's nice because those are things that all levels of learners need to work on. I mean, you can have people that are clinically super advanced who may
Yeah.
not be doing this to
You
the
said
their
role,
ability.
you said role clarity and designated leadership?
Mobilizing resources.
Mobilizing.
The learner will be able to demonstrate coordination of care by.
And if you see something you want to add for your learners,
Just write it on the wall.
yeah. I want them to use cognitive aids
We'll get you a Sharpie.
because you've given them in their pre-work
Working out our own.
So in the debrief, you're specifically looking for, did these learners use their cognitive abilities? Wonderful.
So now we have quality and policy.
Yes, quality and policy. I included.
Rachel, what did you say about quality? What was the objective?
I'm trying to remember now. I don't know if I said a specific one. It was just that like we based our simulations off of quality management reports and like following the policies and like RSI checklists. So like have like making sure they're using their aid to get them through the RSI process.
So we use some visual aids. You can throw the visual aids in your teamwork and communication. And we want them to demonstrate that they're following policies. What other adjectives do we got? Display?
You can display adherence to policy or bullet points.
Look, that's what we do. There's so many adjectives. They can,
Demonstrate,
initiate,
How about display and understanding?
display understanding.
mastery, yeah. So,
Mastery.
but that could depend on your learner too, because I mean, novice learners aren't going to be.
Mm-hmm.
Yeah, I don't know.
problem was, there's a lot of policy changes.
Adhere could be your verb.
Adhere.
Adhere to,
I like adhere. How do y'all feel about adhere?
Because you're following a standard, so yeah.
Mm. Following standards, I like that one too.
I'm curious, have you guys considered using RCDP to teach processes in your simulation?
sorry, what was that?
All right, have you guys used RCDP to kind of teach processes?
I don't think so.
Have you seen RCDP?
No.
Oh, you'll love
It's really cool
Okay.
for processes specifically.
Or at least I don't know if I have. I just didn't know the name of it. But,
Gotcha. Rapid cycle deliberate practice.
Okay. No.
Is designed for
Those
like we were
checklists,
talking about,
yeah.
Things that have a clear answer,
Yeah.
no matter who's doing it. Great suggestion.
Way different than immersive.
Right.
But yeah.
The learner will be able to adhere to institutional policies and procedures as evidenced by.
Yeah. By utilizing. Yeah, like the cognitive aids provided by the institution.
By implementing provided cognitive aids.
And it's whatever you got, like each,
Mm-hmm.
yep, all of your learners, yeah, all your policies are different, yep. Because the answer is, how do you know they're adhering to your policies and institutional protocols?
So what types of, and I'm not asking you to put this in, but like what type of cognitive aids are we supposed to be using in this? Like how would we, we're talking like
checklists.
Like a checklist.
Yeah.
Like an NIH stroke scale checklist or, okay.
Yep.
Or like we had one for STEMmies, like, did you do this, did you do this, did you do this?
Like a normal living checklist
Beta
or
blocker, aspirin.
transfusion. Okay, so that kind of stuff.
Two is good, y'all want another one?
That's three.
I think we have 3.
That's three.
Is it three? Gotta have three.
Teamwork and communication.
They do have 3, I think.
Yep.
Coordination of care and
Adhering to institutional policies.
Oh, yes, you do, I'm sorry, yeah, you guys had fixed the one earlier. All right, so you got 3, that's enough, right? From communication and skills with new students, stimulating prepare for new exams, quality policy changes, basic skills for nursing students, and I don't know what I wrote right here. But out of all of that, we came up with 3 objectives.
okay.
Hopefully that covers everything, right? I think so. All right, plot summary. This is the best part. Let's start with setting. Because you guys brought up a great point. When will these learners cross each other's path? I agree. I always like hospital.
Probably like this outlying hospital that needs to go to a
critical access.
larger, critical access hospital, go into like a tertiary care center.
Yeah, I was going to say, like, with all of these different learning groups that we're talking about, it sounds like transfer of care from one unit to the next, whether it's pre-hospital to emergency room or emergency room to cath lab or med surg to ICU or something. I don't know that it really matters. I think it would be just the transfer. That would be the important part of the setting.
Gotcha.
Agreed?
Okay, so I was like, is there other thoughts on
No,
this?
yeah,
Okay.
I was just
Okay, cool. All right, what do we need? What resources do we need to make this happen? Who do we need?
So we need representatives from all the specialties, like I'm not a flight nurse who would have no insight onto what happens in the helicopter.
I don't even know.
Me.
Me either. Well, I think for that, we would need to decide what kind of patient is being trained. Because, like, you know, if it's a stroke, then you need cardiology. I mean, it's like neurology and radiology.
I appreciate that thought, yeah.
Because what if we used like a doc in the box for like a real thing?
Yeah.
Like, because LPN students would participate in that. You know, they could be the hands and eyes for the doc when they do their online assessment or their ignorant assessment.
Okay.
Because a lot of times that's all we have for neuroconsult.
So we're coming out of the hospital and doing like an urgent care?
Probably. I mean, I hate to think that everything comes from the ER. They just mostly do. I mean, it's going to have to be somebody presenting. Like, say we made it simple. Say we said it was a CDA. And they present, hopefully the students recognize the symptoms, get the doc in the box, with that coordination of care and understanding team roles.
Yeah. And then if there was like a checklist of getting that consult set up, and that could be the policy that we use, and there's like an aid that they can use to make sure they go through all the steps to get that set up.
Because there is a legit one to make sure that everything's in place before the neurologist comes online.
Gotcha. True.
It's a lot just in that, right? Because there's the checklist to make sure that the telemedicine stuff happens. There's the checklist of like signs and symptoms of this, like the initial recognition. There's a checklist of things you have to look at before you do thrombolytics. Then if they decompensate and they need RSI, then you got your checklist there. Like there's a million. There's probably too much to focus on at one step.
I gotcha. Yeah.
I would probably do making sure you have everything set up before you call the neurologist for the video consult, just to make it more
But then,
applicable.
couldn't somebody from one of your disciplines be the consult? I mean, don't they sometimes have residents and people that sometimes do that?
Typically, when it would normally be, I think, a neurology specialist, I think, that would be doing a teleconsult.
Or at least like a fellow.
I'm so glad. I like that you asked her that. And I'm just highlighting again why everyone needs to be represented here, because sometimes we make these assumptions about other specialties that they're like, no, we don't do that. So I appreciate you asking. I'm thinking about two different things. Let me be transparent. I'm thinking, I wonder if we could do this as like a 3-part sim, right? Where every group has to hand off and pull other people into this as the escalation of care gets, as we need to escalate care. That's my thought.
Yeah.
Going with this current sim that you have.
Have like the checklist to set up the consult, and then the SPAR handoff between the sending facility and then like the transport crew, and then have the transport crew use their RSI checklist and route as they decompensate.
Gotcha. I like it.
Yeah.
Because we could actually put them, take their mind and say, you are here at urgent care, so-and-so, so-and-so. These learners interact that would naturally be there. Our urgent care would get them to a hospital, I assume. If they're having stroke symptoms.
When they do those neurology consults from an urgent care?
I don't know a lot about urgent cares.
Yeah,
I think like I've worked at like rural critical access hospitals that are kind of like that, where it's just like if I was the ER physician there, I'm like the only doctor in the hospital at the time, and so those we would do like the teleneurology and then transfer normally. But that's the only scenario I've experienced with. I would imagine like we get referrals from urgent care sometimes, but often they just say, hey, this person seems like they might be having a stroke, so we're sending them to the ER, but there's no like official consult there normally, just because they're not set up to do CT scans normally, depending on where you're at.
And I don't know a single nurse practitioner that would look at a droopy face and say, oh, let's do something with that. They'd be like straight to the ER.
Right, hopefully, yeah.
There's another one you look at, yeah. Not working at ED. So, yeah. All right, just for sake of time, let's skip on, because again, like, this is just us kind of pre-working. All right, so type of simulation. Immersive, procedural, interprofessional, uniprofessional. What are your thoughts? Guys, interprofessional.
Yeah.
And I think immersive would probably be
Immersive
good,
is okay.
Are you using real patients? Doing hybrid?
I think hybrid. I think a real patient would be great for presentation.
Yeah, they're hard to intubate though.
That's true.
Well,
I mean, not really.
Yeah, not really. Following that RSI workout, you get them real sleepy, and paralyzed. Oh, I hear a thought.
Well, if we're doing an RSI checklist as part of the policy, the policy, maybe they don't meet the criteria. It doesn't have to be a positive RSI check sheet. It could be, nope, that's not going to work.
I love your thought. I
So-
love that thought.
So real patient.
Yeah. Is the checklist that y'all use for making the decision to intubate?
No,
or
it's
is
like the procedurals to make sure you don't forget any steps when you're doing it.
Oh, okay.
Yeah.
So the decision has been made already when you start
Yeah.
using it. I see.
Depends on which RSI check sheet, what you're talking about for an RSI check sheet. Because by me, there's extra steps to initiate the RSI. So not actually.
Institutional variability.
Yeah.
So it's not necessarily just, okay, we're going to RSI, here's a check sheet. It's, do they meet the criteria for a crash airway? Are we going to RSI? Do they pass the Lemons, Mohs, rods?
Right.
All those criteria. So maybe they don't.
Well, I guess it depends on what we want to learn. Like, where's the knowledge gap?
Yeah.
What do we?
Right.
Which one of these are we referring to in our objective? Like, are people having trouble identifying people who need it, or maybe intubating it appropriately, or are people forgetting stuff in their RSI? Like, what problem are we seeing?
And honestly, instituting an RSI is this whole separate scenario that isn't, I mean, the
Part of
RSI
your
skills are not
objective.
part of our objectives.
Oh, I think we brought that, I think you might